This is Ron Klein.
Good morning, Ron. We haven't started yet, so thank you for
Okay,
joining
morning.
us by phone.
Eight o'clock is early for you guys. Your part of the world.
Oh, you're just bragging. Let's see if we've got everybody in Las Vegas. Dr. Ford, are you there? The camera doesn't bring it up close, so it's hard to see people.
I'm sorry, I'm not hearing you very well. If you can move the microphone closer or whatever.
Actually, it's right here, so maybe we need somebody to do some technical support. Dr. Ford, are you in Las Vegas?
No. Are you talking to me?
No, I'm asking who's present in Las Vegas.
Oh, I'm sorry.
Hello, Dr. Ford, Ms. Atkins, and Mr. Johnson are here.
Okay, do we have Lynn Atkins yet?
Yes.
Thank you. And Levon Lewis?
No.
Not yet.
Okay, thank you.
We can't see them. Is that?
We can't. You have control of the cameras. We can't reverse to see the north.
We can see each other. We can see ourselves, which kind of seems silly.
Oh, thank you.
All right, we're calling LCB technical support right now. And then Dr. Klein, are you able to hear us better, or should we ask them for assistance on that as well?
No, I'm okay right now. I just heard you now. I'm hearing you better than before.
Okay, thank you. Give us a few minutes, and let's see if we can get some technical support here.
Technology is great when it works. This is Kevin Walters.
Dr. Ford, would you help assist me in Las Vegas for managing the meeting, please? And then once you see that the technical errors have been corrected, would you let us know?
Sure.
Thank you.
There's no way just to reverse it on the top of the thing. I know nothing about IT.
Ms. Atkins or Dr. Ford, is that a different room from the last time that we were down on the Cheyenne campus, or is it the same room?
No, it's the same room.
Same room.
It is the same room. Okay.
No, this is a different room.
Oh, I stand corrected.
That was me. I thought it was the same room.
Different room. We're in
Different
47 today.
Could, if possible, could we ask a representative from GovChaw to go down to the other room, make sure there's nobody sitting out in that room, and bring them over? Thank you very much.
This is weird hearing them in this.
This morning was the same. Good morning. How are you?
It feels the same, but I think
I guess it's just
It's different. The last one was right outside the elevator. I went there.
Yeah, I did too. Okay.
I did too, and I had a moment of like,
I'm just not paying any attention.
okay. They're trying to get us reversed so we can see them. Right now, we just see ourselves.
Oh, no. Boy.
So who are we missing?
We're just missing Leslie, who's Barbara's in North.
That's behind the scene.
He's on the phone.
Oh.
Miss Lewis is here. We're just waiting for Miss Johnstone.
And Ms. Johnstone will not be attending today.
Oh, so
Okay.
we still don't have visual on you yet.
And we'll go ahead and wait a few minutes to try and get that.
Wow. I'd still be on the highway.
Increase.
annoying either.
Dr. Ford, still no reverse sight on this yet, or are you just seeing yourself?
We're just seeing ourselves.
Okay.
And we look great.
We are going to wait because we do have a presentation that will be important for you to see, and if we don't get that reverse fixed, you won't be able to see it. So hang on, and hopefully they'll get it fixed for us here in a few minutes.
Dr. Klein, is there some way for me to see the presentation, log in on the web somewhere?
Yes, if you go to our website and go view meetings or something like that, there's a place to watch it.
Okay. Thank you.
And if you do that, Dr. Klein, you might want to mute your phone because it'll probably create some sort of interference if you're live with us and watching
Sure.
online.
Sounds fine.
Can those in Las Vegas see us now?
What's the website? God.
I think exchange. I have it bookmarked.
Exchange.nv.gov.
There we go. And I go to the link. Now I go to view online.
I can't make it stream.
Come on.
View this meeting on your iPhone.
Oh, yeah.
Ah, shucks. You can't open the page. Oh, I guess you can't. You have to start, right?
I don't know if the Wi-Fi is working. You
Doc-
needed a password earlier.
Dr. Ford,
I'm on my...
Yeah.
if for some reason they're not able to fix that soon, does someone have a laptop there where you could go to live meetings,
Got it.
mute the mic,
Got it,
and
yes.
watch it? Okay, so we got a backup system. Yay.
Well, I got it on my iPad.
I don't know, Ms. Johnstone's here.
Oh, Miss Johnstone has arrived.
Okay, thank you.
I don't know why.
Dr. Klein, are you still with us?
Yes, I'm still here.
Great.
Just getting ready to log into the web.
Well, that's delayed too. All right. I have my hand on my head. Well, now it's just...
All right, we just lost connection with you. We've got it back. So can you see us yet?
No.
And we're just frozen.
Yeah, we just experienced the same thing. So,
That's just weird.
in fact, it looked like they disconnected us for a few minutes and then logged us back on.
Dr. Klein, are you still with us?
Wow, that's a long delay.
Sounds like he's.
Delayed too.
Oh, see, there you are. Careful what you say. I said twice.
I have my hand on my head.
We just lost connection with you. We've got it back.
Are you watching the live stream right now then?
Yeah, but it's like a minute behind. It's pretty funny.
No, we just experienced the same thing.
This is going to be a challenge, I can tell.
In fact, it looked like he disconnected us for a few minutes and then logged us back on. Dr. Klein, are you still with us? That's a long delay. See, there you are.
You,
Okay.
Okay, Yeah. Why don't we do this? I know that they're going to be working on this, and if I find that they're going to log us off, we'll interrupt the meeting at the time. But I think the most important part for you to be able to have visual is for the Xerox presentation. So why don't I go ahead and call the meeting to order right now. Dr. Ford, if you want to mute your connection with the internet so that we don't get that feedback on it. And then I think we just got disconnected.
Can you guys see us yet?
Yes.
Yes.
Oh, we're
Excellent.
fixed. Okay, great. Thank you, everyone.
They're live now.
All right, so if we can get everybody to...
Oh, now you're going to get
I turned it
feedback.
off. Okay.
All right, thank you everyone for your patience. I'm going to go ahead and call the meeting to order this morning. This has been a properly noticed meeting for the Silver State Health Insurance Exchange. We are teleconferencing between Las Vegas at the College of Southern Nevada and here in Carson City at the Legislative Building. We also have phone access where one of our members is joining us, and hopefully we have other participants joining us by phone. So welcome, everyone. I am going to have Mr. Hager, our Executive Director, do the roll call.
Miss Atkins?
Present.
Miss Lewis?
Present.
Dr. Klein?
Here.
Miss Kerr?
Here.
Dr.
Present.
Mr. Wilden, I believe Mr. Duart is filling in for Mr. Wilden. Present. Mr. Johnson?
Here.
And Director Director Johnson. Director Mullenkamp is not here at the present time. We will call their office to see if Ms. Jones will be arriving. And Ms. Johnstone?
Present.
And Chair Campbell.
Present.
We have a quorum.
Thank you, Mr. Hager. Do you have any announcements? I don't this morning. So, all right, with that, I will open the meeting up to public comment. Do we have any public comment in Las Vegas?
Doesn't look like it, Madam Chair.
Thank you. Any public comment here in Carson City? If you will come forward, please. Identify yourself for the record. And if you use, there's a little white mic button there. You'll need to press that so everyone can hear you. Thank you.
My name is Al Schubert, and I'm with VSP Vision Care. We're a licensed, the largest licensed vision care entity in the state of Nevada. I wanted to thank the Silver State Health Insurance Exchange for the excellent work that you're doing so far on behalf of Nevadans throughout the state. We are one of the largest insurers in the state of Nevada by membership, but because vision care is all we do, it's a different revenue stream, as you can imagine. Presently, 1 in 4 Nevadans get their vision care through our organization, VSP Vision Care. That's exactly 26.3% of the entire population of the state. We're often known for our large employer contracts, including the Teachers Health Trust, Boyd Gaming, Clark County, the Venetian, Washoe County School District, and Ameristar Casinos. However, what most people are not aware of is that we contract with 596 employers in the state of Nevada. And 81% of those employers are right in the target audience of the Nevada Health Insurance Exchange. 81% are less than or equal to employers of 100 employees. 76% are less than or equal to employers of 50 employees. And the important thing is that 90% of all of that vision care is delivered through standalone vision plans like our organization, as opposed to through a qualified health plan or major medical. The reason why I wanted to speak to you today briefly is that the essential health benefits and supplementals need to be a comprehensive eye exam, and we support the recommendations of the Nevada Optometric Association in this regard. The preventive benefit component of a comprehensive eye exam is based on clinical fact, particularly as it relates to the diagnosis and treatment of diabetes, glaucoma, and hypertension. VSP also recommends the FedVIP benefit level for the essential health benefits and for the supplementals. That benefit contains the important preventive services, but also contains materials for beneficiaries. At the same time, thank you for your efforts so far in preserving the standalone vision plan and standalone dental plan delivery system that already exists in the state of Nevada. We are advocating to cover beneficiaries both with the pediatric vision component in the essential health benefit and supplemental coverage for adults. And I beg you to make certain that there is separate pricing which would foster competition and certainly mirror the private market in the competitive marketplace that we deal with. Additionally, we're willing to do our part by including in our rates an assessment on carriers, but I would also ask that you consider, rather than basing that assessment on enrollment, that you base that assessment on premium. Based on my initial statement, the revenue stream for a vision premium is typically cents and not dollars, and it's far different from the multiple and hundreds of dollars in many cases on a major medical premium. Finally, you may be aware that you're not alone on this particular issue and the progress that you've made so far as standalone vision plans and standalone dental. The states of Maryland and Massachusetts have already moved forward in both the areas of recognizing standalone dental and standalone vision plans as it relates to both the pediatric essential health benefit and supplemental benefits for adults as well. They've also opted to take it a step further and make that enrollment a seamless enrollment experience, if you will, with the exchange, primary exchange enrollment. Once again, that fosters competition and mirrors the private market, and including in the state of Colorado, currently today, both Massachusetts and Maryland, and most recently the state of Colorado, have instructed their IT vendor to build out their web and enrollment infrastructure to handle standalone vision plans and standalone dental plans in the way that we currently are recommending. Thank you very much for taking a couple of minutes and our public comment. I'd be happy to answer questions if that's appropriate.
You know, I think for public comment, we don't have a question and answer period. I'll check with Keith Marcher.
Not generally, but you can respond to his comments if you'd like.
Okay. Thank you. Well, I appreciate you taking the time to come forward and giving us some information on the vision component.
You're welcome. Thank you very much.
Thank you.
Good morning. Very briefly, my name is Elisa Caffaretta, and I'm here on behalf of Nevada Advocates for Planned Parenthood Affiliates. And I just would like to make a request for your next meeting. We know you have several very significant agenda items coming up, particularly around the navigators and brokers roles. And we have all provided a great deal of public testimony and public comment, but we are constrained that you can't have a back and forth dialogue with question and answer. And so possibly for that meeting or that particular agenda item, it might be set up similar to a legislative hearing that would allow you to ask questions of the folks who want to play those roles and allow you to get more information. So we just would ask as you come up on some of these very major significant decisions, essential health benefits, navigator role, that you might consider setting those up as a hearing format in the future. Thanks.
Thank you, Ms. Caffaretta. We appreciate your comments. Any other comments here in Carson City?
For the record, John Hager, I wanted to point out that there are two public comment items that are online for the board's review, one from the Nevada Optometric Association and one from Aetna.
If we have no more public comment, I'm going to close that part of the hearing and we'll go to the approval of the minutes. So members, if you've looked at the minutes for June 14th, 2012, are there any additions, amendments, or corrections to those minutes? Hearing none, may I have a motion to adopt and approve those minutes?
Lynn Atkins, so moved.
Marie Kerr, second.
Thank you. So we have a first by Lynn Atkins and a second by Marie Kerr. All those in favor of the motion?
Aye.
Any opposed? Thank you. The motion carries. Now with the minutes from July 19th, 2012, are there any additions, amendments, or corrections? Hearing none, may I have a motion to approve?
This is Leslie Johnstone, so moved.
And do we have a second?
Marie Kerr, second.
Okay, so we have a motion by Leslie Johnstone and seconded by Marie Kerr. All those in favor of the motion?
Aye.
Aye.
And Dr. Klein, you still with us?
Yes, I'm still here. I approve both.
Okay, thank you very much. I just want to make sure we still had you on the connection there.
Yeah, it's going to be a little bit fun. There's a 5-second, 10-second delay between the website and the phone, but we'll have fun.
Okay, thank you. All right, the next item on the agenda is our executive director's report. So I'm going to turn this portion of the meeting over to Mr. Hager.
Good morning. For the record, John Hager. So the executive director's report, much similar format to previous reports. For the advisory committees, we've made quite a bit of progress with the 5 advisory committees. Finance and Sustainability, you'll see most of their recommendations today. With those recommendations, assuming the board doesn't send anything back to the committee, that will close out the finance and sustainability responsibilities. Keep in mind that we've discussed in the past that if we would like to bring them back, we can bring them back in their current format. If there's something that the board wishes for them to review, so it's not necessary that we go through a whole other selection process for these committees. Plan certification and management, we have 2 meetings scheduled coming up, one for August 20th and one for August 29th. The big topic, of course, will be essential health benefits. We have an actuarial evaluation that should be coming to that August 20th meeting. Hopefully, we'll get that out to the public on Friday. We realize that doesn't give a whole lot of time to review that, and so that's part of the reason why we've got that extra date for August 29th. We wanted to give everybody the chance to take a first look at it, ask staff some questions. We could go back and come back with answers on the 29th. So the board should expect to see recommendations from the Plan Certification Management Committee regarding essential health benefits at its September 13th meeting. Keep in mind that essential health benefits are market-wide. They're not just for the exchange. So any recommendation going to the board and anything that was approved by the board would be a recommendation to the Division of Insurance. It would not be a final EHB package just because the board said it is. It's a market-wide issue. We have a specific statute that says that we will not impede the commissioner's ability to regulate insurance, and therefore, because it's market-wide, we can provide a recommendation to the Division of Insurance, but not a final answer for that. Consumer assistance has made quite a bit of progress on the role of navigators and producers, and one other group called assisters. We're trying to change the name to outreach specialists because whenever we say assisters, everybody asks about the brothers, and that's not. It's a little confusing. We're bringing that back to the Consumer Assistance Committee with a couple of fine-tuned recommendations, a couple of items that upon further discussion with the Division of Insurance, we need to make sure that the committee still wants to go forward in that direction. But it appears that they've got some good recommendations about navigators and brokers, or producers, and so that will also appear at the September meeting. The shop committee made all of their recommendations, and then we found that we overlooked one regulation. So we want the shop committee. We would like the shop committee to meet one more time on August 21st to discuss that item. It shouldn't. I don't expect it to change the recommendation substantially, but they need to consider the minor change. And again, that will be coming to the board in September. Reinsurance and risk adjustment has a meeting on August 27th, and working with the Division of Insurance, we hope to provide some good recommendations for the September meeting as well. Contracts. The BOSS contract was approved on Tuesday. So the contract between the Exchange and Xerox Healthcare Solutions, LLC, has been approved. So we're going forward, and you'll see in the agenda today we have a presentation by Xerox to introduce their, or to provide a web demo of their product, about a half hour for the board, and then we'll discuss the issue of who does individual billing. We also had the independent verification and validation contract with Public Consulting Group approved by the Board of Examiners. You'll recall that both of these contracts were ratified by the board on, I believe it was August 19th. So the Board of Examiners approved both of those items this past Tuesday. Consulting and actuarial services, I believe that will be going out. That will be going out to the RFQ. The request for qualifications will be going out in the streets, I think, at the end of this week. So we'll be getting that out to the potential vendors, getting bids back, and I expect that we will have this before the Board of Examiners at the November meeting, which means that we'll have about a month where we won't have consultants. There'll be a gap. We weren't able to get it done earlier than that. I think we can still proceed with the expertise that's available to us, but it would be nice to get those consultants back on board. So we'll get that to the November BOE. Auditing services, we've got a request out right now, a request for qualifications, or I guess it's an informal RFP process for auditing services, and so we'll be getting. We've already gotten questions back from the various auditing firms, and that will be to do an audit of our finances and operations, or I can't remember exactly how it says that in statute, but so that should be a contract that is up for approval in the next month or so, probably 2 months. Marketing advertising services, that RFP will probably go to the December Board of Examiners meeting, and so we're on track still to get that on the streets as scheduled. The Memorandum of Understanding has kind of gone back and forth. We had a very bare-bones memorandum of understanding between the Exchange, the Department of Health and Human Services, and the Department of Business and Industry Division of Insurance. When we showed it to the Center for Consumer Information and Insurance Oversight at CMS, they indicated that it wasn't enough, and we had to add a bunch of items to it. And then about a month later, they said, "Oh, never mind. Do whatever you need to do to get it done." So we are going to bring that back finally in September for the board to review it, and both the Business and Industry and Department of Health and Human Services have both approved the MOU as it stands. I don't imagine there'll be too many, if any, changes by the board, but it'll certainly be available for review. The Affordable Care Act funding of state exchanges. You might recall previously guidance from CMS CSIO indicated that there would be no funding available in calendar year 2014 for maintenance and operating. They have since reversed that decision. On June 29th, they sent out a frequently asked question that indicated that we would have funding for our maintenance and operating for 2014, and that's about a $12 to $15 million boost for us. So that will help us out in our finance and sustainability plan that we'll talk about later. And then you also see on page 5 our board calendar and the items that are coming up. With that, I'll be happy to take any questions.
Any questions from Las Vegas?
Ron Klein, I have a question for John Hager, if I might.
Yes, Dr. Klein.
John, do I understand correctly that the health insurance that our board will vote on an essential benefits package, but that the Commissioner of Insurance could overrule us?
That is correct. I believe that the Division of Insurance will review our recommendation, and they will review they may or may not have other stakeholder meetings outside of the board, but yes, there will be various inputs that they receive. So the recommendation of the Division of Insurance may not exactly match what the board recommends.
And the federal government is okay with that? CSIO is okay with that?
The recommendation has to come from the state. CSIO has not indicated which entity in the state provides the recommendation. However, because our statute, and I believe it's 695I, Section 520, indicates that we will not impede the ability of the commissioner to regulate insurance, I don't think that we have the authority to make that recommendation to HHS. I think we have to make that recommendation to the Division of Insurance.
So, Dr. Klein,
thank you.
I think what you're seeing is that we're working within the Nevada statutory scheme, and I think that's why it's been so important that we have business and industry with us. And I know Commissioner Kipper has been, I don't know if he's down there in Las Vegas or not, but I know that he's following our proceedings closely and working quite closely with John Hager and staff. Any other questions from Las Vegas? How about here in Carson City? None? Being none, thank you, Mr. Hager. Good report. All right, so did you want to go over that review that you put together on the Supreme Court decision for us, please?
I could briefly go through that in just a few minutes. Again, for the record, John Hager. So item number 5 is a review of the Supreme Court decision regarding the Affordable Care Act. This is not a legal review or legal opinion, although we did review several legal reviews to make this review. But basically, and I know this is a little bit delayed because we canceled the July meeting, but I wanted to make sure that the board had our opinion on what we see happening from the decision. So basically, the Supreme Court said that the individual mandate was unconstitutional on grounds of the Commerce Clause, but that it was constitutional on the grounds of Congress's ability to tax. And therefore, the Affordable Care Act, as far as exchanges go, is going to continue as it is written. They indicated that the decision to require everybody to expand Medicaid is optional, and therefore states have to make a policy decision on whether or not they want to expand Medicaid. All of the opinions that we've seen so far indicate that they can either leave it as it is in the current enrollment or current eligibility, or it can expand Medicaid up to 130% of the federal poverty level. And there are some questions still about whether or not they can expand it up to 100%, which is the lower threshold of where the subsidies come from for the exchanges. Now, that said, this board has no authority or no discretion over the decision of Medicaid expansion. While our budgets are linked, our budgets will be impacted by the decision of Medicaid expansion and whether the state determines that it will do that. We have no authority over whether the state will actually expand Medicaid or not and to what level. So I want to make sure that's very clear. So that said, everything going forward up until this point, up until the Supreme Court decision, had assumed that exchange eligibility would start at 138% of the federal poverty level, and it would go up from there. You would be subsidized from 138% FPL up to 400% of the federal poverty level, and then above that you would receive no subsidies, but you would still be eligible for the exchange. When that expansion became optional, we had to review what is the actual lower level of the advanced premium tax credit, and it turns out that that goes all the way down to 100% for most individuals. Now, the original act assumed that everybody would get Medicaid, and therefore it only allowed an exception below 100% for those that are not eligible for Medicaid, for non-citizens who are in the United States legally, so who are authorized non-citizens in the United States. They would be eligible for the exchange down to, there's no floor, so they would assume that they would get 100%, where they get the subsidy based on somebody who has 100% income equal to 100% of the federal poverty level. It did not contemplate that for citizens, therefore if you are a citizen, you would not get any subsidy below 100% of the federal poverty level. The brief also discusses the tax for failure to maintain minimum essential coverage, and the gist of it is that the penalty for not having minimum essential coverage is 1% in 2014, 2% in 2015, and 2.5% of income in 2016. There are some floors to that, some minimums, and you can see the various tables that are provided on page 8 and 9 about the differences in the premium at the second lowest level and the penalty. But with that, I will wrap it up and ask if there are any questions.
Any questions from Las Vegas? Dr. Klein?
I'm fine, thank you.
And Ms. Kerr?
Well, we do assume, and maybe it's wrong to assume, that at some point the legislature will fix that non-citizens get below 100% of the FPL get a subsidy while citizens don't. Is that a fairly safe assumption?
So that decision would have to be changed. It would take an act of Congress to change that. It would have to be changed by Congress because it's specific to that act. I think that whether or not that gets changed or fixed depends on states' policies on expanding Medicaid. If everybody expands Medicaid, there's no reason to fix it. I imagine that there will probably be some states that don't expand it, and so there might be some legislation that goes forward to fix that. But there's, of course, a cost associated with that. So it's difficult to say what Congress will do in the future.
Let's assume that it doesn't get fixed by Congress and that Medicaid expansion doesn't occur in Nevada. And maybe it works, just going hypothetical too much. In that case, is there something that the board can do? And do we know what the impact in Nevada is of this percentage of persons who are below 100% of FPL, who are citizens, who are not going to be able to get a subsidy? Is there something that we can do to just maybe start thinking about it, how we can just deal with that issue?
At this point, I'm not sure there's anything that the exchange can do about those below 100% of the federal poverty level. I think that we've got plenty of meetings between exchange staff, DHHS, Medicaid staff, and Division of Insurance, if necessary, to talk about these items. But ultimately, I think this is a policy decision that will have to be made by our elected officials.
Do we have any other questions? There being none, let's go on to the next part of your report, Mr. Hager, and that is the introduction of Xerox.
For the record, John Hager. So as stated earlier, the Board of Examiners approved the contract with Xerox Healthcare LLC, and they are here to provide a demonstration, about a half hour, plus questions for the board and the public to get a better understanding of what their product provides. They are contracted. Their subcontractors are Choice Administrators in California and KPMG. Choice Administrators provides exchange services. I think they have 5 exchanges set up. And then KPMG is basically a quality control entity. They'll be keeping them on track. So with that, I will turn it over to Xerox and let them introduce themselves and say welcome.
Thank you. If I can get both of you to give your name and introduce yourself for the record, and then I'm going to check with Las Vegas and Dr. Klein to make sure they can see what we're seeing here.
Good morning, Greg Vidiello with Xerox.
Good morning, Joe Dela Cruz with Choice Administrators.
In Las Vegas, can you see the presentation or the?
Yes, we can.
Okay, and Dr. Klein, can you see it?
I'll tell you in a few seconds when the website catches up.
Okay.
Yeah, I can see it now. Thank you.
All right, thank you. Gentlemen, proceed.
No.
I think it's a live demo. It's a live demo.
That's a slide.
Are we having problems down in Las Vegas?
There's a question about whether or not this presentation will be made available to the public now or in the future.
Yes, the presentation will be made will be posted to our website so the public can see it. I believe is there a live demo portion of it, or is it all part of the presentation?
There's a live demo.
So the live demo part will not be part of the made public, but the presentation itself will be provided on our website this afternoon.
Morning, ladies and gentlemen. Again, my name is Greg Vidiello, for the record. I'm Vice President for Xerox Health Insurance Exchange and Eligibility Services. And today I'm happy to be here and would like to take a few minutes just to introduce our team. Joe Dela Cruz, who is our project director with Choice Administrators and will be responsible for providing the web demo later this afternoon. I'm also joined back here by Bill DeLang. He's going to be our Executive Account Manager. Jeff DeJura, who's Vice President for Exchange and Eligibility Services. Jennifer Wadham, who is our Solutions Director. Eduardo Garcia, who is our Business Operations Subject Matter Expert. And Matt Benton, who is our Implementation Manager. Today, we're going to spend some time discussing the Xerox partnership for the Silver State Health Insurance Exchange, the roles that the Xerox team members will be playing, why the Xerox team was chosen, and then, as I said, a demonstration of the system that we will be building for Nevada. When the Affordable Care Act was first signed into legislation, Xerox set out to find partners who were best in class in the industry. Xerox, just in case you don't know much about us, we're one of the largest government healthcare services providers in the nation. We have over 40 years of experience serving 38 million consumers across 23 states. Choice Administrators, you may or may not know, was the first private exchange in the nation, the first ever defined contribution exchange, and the first ever ancillary benefits exchange. And they currently service a network of over 30,000 brokers. KPMG is recognized as a knowledge leader in health and human services initiatives. They were a key contributor with the Mass Health Connector and are going to be working with us directly to ensure that we're implementing based on the requirements for Nevada. Our solution is comprehensive, end-to-end, and kind of out of the box. Our solution includes a shop and compare, eligibility and enrollment services, policy management, financial services, program maintenance, customer relations, and exchange infrastructure. Just to briefly go over what the various roles are that our team members will be playing, Xerox will have the overall project management oversight for the implementation and ongoing operations. We'll also hold the Customer Service Center and have responsibility for training and reporting oversight. Choice Administrators is developing and delivering the overall solution, which includes the carrier management, financial services, the web portal, shop and compare tools, and the online enrollment, as well as the other things you see here on the slide. KPMG will have the project quality management and overall ensuring that we are implementing based on the requirements for Nevada. So why was the Xerox team chosen? Partly due to the risk mitigation and speed to market. Our existing exchange software covers at least 75% of the individual requirements, as well as 90% of the shop and technical requirements. Our knowledge of the Nevada insurance market. In 2011, you may or may not know that we worked with 1,200 Nevada brokers who produced more than 165,000 quotes and serviced more than 40,000 residents. And demonstrated track record, as we've said before, we have award-winning call centers across the nation and around the world. We've been operating health insurance exchanges for more than 15 years and are currently engaged with 10 different states on HIX engagements through KPMG in Connecticut, Massachusetts, Missouri, New Jersey, New York, and several others if you're so interested. The other thing, I'm happy to let all of you know that we are bringing over 600 jobs overall to Nevada, 40 of which are related to the health insurance exchange, and then there'll be more than 500 jobs in the Las Vegas area with another contract that Xerox has currently won. And with that, I'd like to pass it over to Joe De La Cruz, who will provide you with the system demo.
Okay, good morning, everyone. My name is Joe De La Cruz, Project Director for Choice Administrators. I'm going to take about the next 20 minutes we have allocated for this to go over really the Silver State Exchange. This was a demonstration we created based upon the RFP that was issued and the requirements that were set in there. As you all know, there are many components to the exchange, especially from the actual platform itself, how it services members in a unique customer experience, world-class customer experience, and gets them really to where they want to go so they don't get lost. Purchasing insurance, especially if you're not using a navigator or broker, can be quite tedious. So the idea here is that this exchange portal that we have definitely puts someone through a no wrong door process, walks them through the shop and compare process, into enrollment, and then into actually servicing their plan throughout the year. So what we're seeing here is the landing page for the Silver State Exchange. Quite a few features, lots of ways to contact, get help. They can log into their account if they are currently a member or have an account. But really the key here is that this is the no wrong door page. So we actually have 4 paths depending upon what role you play, if you're an individual or family. We have an employer or small business path. There's an employee path, as well as a broker navigator path. Just because of the time constraints, what we're going to focus on today is the individual and family path. So I'll click on as individual and family. Here I can choose to just simply browse plans if I'm just kind of looking to see what's offered through the exchange, or I actually can go ahead and create an account and start my enrollment process. As we create an account, it's very simple. As if you've gone to Amazon, anywhere else, you've created some sort of account on the web. It's pretty straightforward. And we also have this translated in Espanol currently, so that's also in sight as far as this particular exchange is concerned. So I've got an account created, and just for the sake of time, we've got some pre-populated information in here. So what we're showing is I would build my household information. So we have Daniel Smith, Nevada resident. He is a male. We're going to ask some questions so we can further determine the right path for him and the right products for him, such as household income, primary tax filer. Daniel's also going to go ahead and build his household, the members of his household, and submit some information. Once his household has been built, we're going to submit that over to the SSHIX verification process. So at this point, we've captured enough information to send it over to SSHIX and have them return some sort of verification of income, of citizenship, of income, So we're going to ask a couple of things here just as a secondary security question before we display the information that we found. So once that's confirmed, it comes back showing the makeup of the family. Daniel Smith, in this particular instance, had an annual income last year of $30,000. Anna Smith, annual income of $15,000. Obviously, the kids, no income there. And current coverage is unknown. If this was a repeating customer coming into the exchange, they would see the prior year coverage. We've also validated that everyone in the household is a U.S. citizen and everyone is a state resident. At this point, if the applicant felt the information was incorrect, they could process a correction request. If they felt the information was correct, they could go ahead and move on to the next step. So based upon that information, the system does some pre-eligibility determination, saying based upon what we know of your income in your household, you could be eligible for low or no cost health care plans. Would you like to check eligibility? At this point, we would have the state application up. This is just an example of the application. We would be obviously looking at the state's eligibility system to build out the questionnaire so they can fill that out through the exchange. So at this point, we've just got some high-level questions. I'll go ahead and put in that Daniel's disabled. Once that application has been completed, we then hit the state's eligibility rules engine. And that's going to return eligibility response. So in this case, Daniel would be eligible for Medicaid based upon his disability, and it would be eligible for a subsidized individual plan, and the children would be eligible for CHIP. We also envision, since they're eligible for government-assisted health care, they may also want to check eligibility for non-health care public programs such as SNAP or TANF. If they felt the results were incorrect, they can go ahead and process an appeal form right through the exchange as well. If everything seemed to be in order, they can continue on to the next step, which is really the shop and compare process. Move back up. So this is the shop and compare piece that we have. Obviously, there's lots of elements, probably one of the busiest areas of the exchange that we have, but it's also the most informative. So I'll walk through kind of the key pieces here. Off to the left-hand side, we have an out-of-pocket calculator. We also have further filters that the consumer can filter by: metal types, monthly premiums, deductibles, things of that nature. There's also a physician finder and an RX finder. In the middle, we actually have the summary of the plan that they're considering at that point. They can also add that into a comparison so we can do side-by-side comparison. So we'll get back to this family makeup. As we recall, Daniel was eligible for Medicaid. In this particular instance, Medicaid, there is just one plan, so kind of a no-brainer there. We'll go ahead and add that right into the cart. The next set of folks I'm going to shop for is for Emma and John, and that would be the CHIP program in Nevada Checkup. We'll go ahead and enroll them into that plan. And then the last one here is going to be for Anna. She is the one that's eligible for a subsidy into a commercial program. And this is where I'll go ahead and do some of the cost comparisons. So as you see here, we've got some illustrative plans. Obviously, these are not the actual plans that will be out there. They're still being written or being designed, I guess is the best way to put it. But we have we show some annual out-of-pocket, deductible, office visit, generic, specialist, some of the key things that people would care about when considering the plan. They could further look at benefit information by clicking on plan details and looking at the other benefit designs of that plan. There are sorting options available to them as they move forward. So what we have off to the left-hand side is the out-of-pocket calculator. Right now we have it set to some typical usage patterns. However, the user, the applicant, can actually adjust those to what they feel is applicable to their needs in the coming year. So primary care office visits, they may say, I'm going at least once a month. I don't anticipate any emergency room visits, no 2 specialist visits, and I don't take any brand drugs, but I do take 4 generic drugs. And what you're going to notice, that out-of-pocket cost is going to start to calculate based upon the usage inputted into the cost calculator. and this is applied towards all plans being considered. So if we move down, we'll see that our annual out-of-pocket increases based upon the plan design. The applicant also has the ability to do side-by-side comparison of plans. So I'll move down here and grab a few. And we'll click Compare Plans. So there's a side-by-side comparison of the different benefit types and the levels there that are offered. So really, once the decision's made, they would go ahead and simply add that to the cart. And at this point, Daniel knows that he's got coverage for Medicaid. He has his children, Emma and John, in CHIP. And Anna is now in the United Healthcare Saver 90 plan. It's total monthly premium. And at this point, he would go ahead and apply. We would then direct them either to an online application, which obviously is a preferred route, or, if needed, print and mail application. That is the mixed eligibility for individuals and members. That's the demonstration we have here for this path. Is there any questions at this point?
Joe, just let me ask a question. If you scroll down further, yes. The first couple of them show a subsidy, but as you go down further, it doesn't. There. You don't show a subsidy on that? Is that just because you haven't populated it, or?
No, the way that the subsidy works is that it's going to be subsidized based upon the silver level plan. So the subsidy would apply to that plan the way that's being interpreted right now. So if you were to choose a bronze or gold plan, the subsidy would not follow into that plan. But again, this was just an illustrative example.
So those are non-qualifying subsidy plans that you can choose?
Non-qualifying
okay,
plans.
Thank you.
Madam Chair, can I ask a few questions?
Sure.
Thank you. For the record, Charles Duarte. So for the enrollment choice, and I'll talk specifically about Medicaid because that's what I do, the applicant, will they be given an option of Medicaid HMOs as well as our traditional program, or do they have to apply separately for that?
So that is part of the design discussion that we need to have with the state.
Right.
So we know that the state's existing eligibility system will have, really what we're doing is we're providing the no wrong door approach so they understand what's available to them. They may branch off directly into the state's eligibility system to complete that application in whatever way it's being done today. Or we can decide to go and incorporate that into the overall application that would happen from the exchange and funnel that enrollment eligibility information over to the state entity that would go ahead and essentially make that active.
And so, obviously, we need to talk about that. The sort of corollary question is whether or not, if they are Medicaid eligible and enrolled in an HMO, a Medicaid HMO, whether they would be able to select their PCP similar to what they do with an exchange plan. So that would be another issue I guess we'd have to bring up and discuss. And then premium collection. Our Nevada Checkup or CHIP program has a monthly premium.
Yes.
And you're aware of that. Good. What would your plans be for families that don't have a credit card?
That don't have a credit card, so they would they pay by check or pay by cash?
I assume check or cash. We receive both.
Okay. So the way it would work right now, depending upon how this happens, is we definitely take check payments through our lockbox services.
Okay.
Our lockbox service also does take cash. If we get people that will put in the mail a bunch of quarters, to be honest with you, and we actually will go ahead and process those. What we don't have are retail outlet centers or somewhere to where we could collect cash that way, and that's something we would need to consider if that's a requirement. But there's lots of different ways to solve that. If there's currently a cash collection vehicle out there where someone can walk up to a brick and mortar shop and put down their payment, we would work with the state to how do we track and record that payment and deposit those funds.
Yeah, that type of recording and documentation and then reporting to the state is going to be important for us to maintain and report back to the federal government. So anyway, thank you very much for the opportunity to ask some questions.
Great.
Any questions from Las Vegas? How about you, Dr. Klein?
Sorry, it's Dr. Klein. May I ask a question?
Yes, you may. Go ahead, please.
Thank you. Sorry, I was on mute. Just a couple of questions. First, it looks like a beautiful system, so my compliments. This is obviously our face to the world, so it's nice to see a nice portal. Perhaps it's my lack of understanding, but I sort of always imagined families buying insurance as opposed to individuals. So in that demonstration you had the child with one system, the mother with another system, presumably the husband with a different system. So how does this work if a family, if the families, how does the family become eligible for the exchange?
That's a great question. So in the scenario that we had played there, that was the mixed program eligibility and how they would enroll into both commercial and public programs. Typically a family would qualify overall. You would enroll them all into Medicaid depending upon certain circumstances. This was probably one of the more complicated scenarios based upon eligibility rules. But yes, a family would go in and shop for a singular plan. They would go ahead and cover the entire family in a typical IFP type scenario. So I would go with the HMM40 with my 3 dependents, and that would be my information. So the portal itself does support that. So we were demonstrating more of a mixed program where I need to have one. We've got a different plan comparison for the CHIP program versus the Medicaid program versus a commercial program. I hope did that answer your question?
Yes, yeah, it did. Two quick questions. 2 more quick questions. One, you're going to support PayPal, I presume, when you talk about credit cards?
Yes, absolutely.
Okay. And then the final question, when I saw the website and I saw everybody's name and birth date and social security number, I was thinking that was really an identity thief's paradise that you were showing. So I presume there's going to be some very heavy security so that what happens so often where people lose their identity through a website won't happen here.
Absolutely. So there are very strict security procedures around the website itself, and then also capturing that information in a HIPAA high-tech compliant fashion. So we're very familiar with that, and we hold that very true and tight to our.
No, and I'm sorry, I'm not hearing you terribly well, but I guess the question would be: so somebody has just like on Amazon or eBay or whatever, you have a name and a password.
Oh,
it just seems like if somebody gets a hold of your name and password, or just through brute force computing, figures out your password, they have access to your whole family's social security numbers and birth dates, and your identity is gone.
Very good. No, I understand that. So that's masking of that vital information that should, that needs to be private. Yes, actually, again, this is a demo system. In our production environments, we allow for input of social security number. However, when it's redisplayed, it is masked. So we'll show the last 4 digits and nothing more. That's both
Thank you very
social
much.
security and credit card.
Madam Chair, sorry. Madam Chair, Lynn Atkins.
Yes, go ahead.
And this might be a question for Mr. Hager. I wonder if it's possible at our next consumer assistance meeting to have this maybe 10 or 15-minute presentation of how the web portal is going to work. I think we've been working with information that we've kind of been imagining, and I think this to me starts really clarifying the role of navigators, the role of brokers, the role of assisters, or whatever terminology we're going to use. I think as fabulous as this system's going to be, I still think it's clear to me there's going to be a lot of people who aren't familiar with computers, who aren't familiar with the filters and how you kind of use this website. And I think this will help our discussion about navigators and brokers and producers and everything. So I don't know if that's possible, but I do think it's actually critical, and I would ask that that be done maybe at the beginning of our next consumer assistance meeting.
For the record, John Hager. So a question to Xerox then. Our next Consumer Assistance Committee meeting is on August 29th, on Wednesday, August 29th at 1:30 p.m. Can you have somebody here to provide this demonstration at that point too?
Yes, absolutely. We'll commit to that.
Thank you very much.
I have a question, quick question.
Go ahead.
Hi, this is Dr. Ford. Yeah, hi, quick question. What do we know about the turnaround on IRS verification? You know, in this presentation, it happened in about 4 seconds. Do we have any more information about what is the real-time turnaround on that?
For the record, John Hager, we do not. We've been asking that. They are sounding more positive as time goes by, but the latest official answer is that real time could be 24 hours. So that is certainly a concern for us. It's a concern for Xerox, for all the states and all the vendors out there that are working on this. we will continue to push to make that as real time as possible, preferably within about 15 seconds. I think that's kind of the standard, what we would hope for. Obviously, if this goes to a 24-hour turnaround, we've got to completely rework all of our flows. At this point, though, we need to proceed as if we will get that real-time turnaround in about 15 to 30 seconds.
Any other questions from north or south? All right, thank you. You want to proceed?
Yeah, actually, that was the end of our demonstration. Just like take it back over to Greg, but on behalf of our partnership, looking very forward to working with the state of Nevada and getting the Silver State Exchange up and running.
And that's it for our presentation, unless you have any additional questions for myself or a team member.
Okay, knowing that that's the end of the presentation, I'll ask one more time. Are there any more questions from board members? Or from the state with regard to this? I know, Chuck, you asked. Okay. All right. Well, thank you very much. We appreciate you being here today, and the presentation was very, very informative. Thank you.
Thank you for the opportunity.
And I hope you are staying for the next discussion, because I think it's part of what you're planning on doing. So, at any rate, Mr. Hager, let's move on to item number 7, which is the discussion regarding the individual premium billing.
For the record, John Hager, Executive Director. So part of the function of an exchange is to provide premium aggregation. Now, it's required for the shop exchange, for the small employer exchange. It is optional that the exchange do premium billing for individuals. So there's a couple of parts to that. So first of all, this discussion will only be around individual premium billing and whether or not we as the exchange, and when I say we, in this case I mean Xerox would be doing this for us, or whether the carriers do it on the individual side. Now you saw in that web demo the case where you had the family, two kids and CHIP, one person on the qualified health plan. The idea would be that if Xerox were to do individual billing, then that family would get one bill rather than a bill from the qualified health plan and a bill from CHIP. There's a couple of caveats, a couple of things that make it a little more complicated. And one of those items is that there is a regulation that states that we have to allow an individual to pay a carrier if they want to pay directly to the carrier. But it's not, we have to allow that, but we don't, but we can also set up the system to encourage that the individuals basically pay Xerox, who would then distribute the funds to the carriers. So there's a whole lot of information in here, and I'll try and step through it. I hope that the board had a chance to read this, but I'll go through it again. But basically, the paper-based premium billing and payment, it's a complex process. Carriers have done a lot of work to make sure that their systems are able to bill accurately. Xerox and Choice Administrators has also done a lot of work to make sure that they bill accurately. So I think no matter which way we go with this decision, I think the individuals will get accurate bills. The question is a matter of branding for the exchange and a matter of cost. So again, the idea of aggregating the individual billing is that a family would receive one bill rather than several bills, or two or more bills potentially from the carriers and from CHIP potentially. The other part of that is we also have ancillary products, dental, vision products that will be sold through the exchange, potentially other products that we haven't yet decided on. And so the dental, vision, and the major medical could all be included in one bill for the individual. So it's not just a matter of medical qualified health plans, but it's also a matter of getting one bill for all the ancillary products that typically an individual that's employed would get, but not necessarily the individuals would get those same benefits, but they'd have to pay separately. So somebody that's employed would get a premium deduction from a deduction from their paycheck, and it would all go through the employer. Again, on the employer side, it's required that the exchange do this function. On the individual side, it's optional. So it's possible to streamline the premium billing payment process to the benefit of both carriers and their customers. The advances in automation and support technologies make it possible to migrate to paperless billing and payment, which a lot of carriers do, and also to consolidate premiums for multiple products, even multiple carriers, into a single electronic bill that consumers can easily reconcile, adjust, and pay via a self-service portal or via a paper bill. Again, the regulations require that the exchange provide each qualified employer with the bill on a monthly basis, that they collect the funds from the employer and distribute to the individual qualified health plans, and then that we as Xerox in this case, maintain the books, records, and documents and other evidence of the accounting procedures and all of the payments for the last 10 years to ensure proper reconciliation and accounting of funds. So again, the business operations solution contract includes, or the contract with Xerox includes the ability to, or the requirement to do premium aggregation for shop employees and employers, and the option to do it as for individuals. So you've seen the demonstration. This report includes a few of the additional advantages to carriers, individuals, and to the exchange. One item to note, if the exchange chooses to do individual billing, then we would also do billing for the 20,000 some odd children enrolled in the CHIP program. If we do not do individual billing, then Medicaid or welfare will have to create a billing system. Their current billing system needs to be updated, so they will have to update their current billing system to allow for bills to be sent out for CHIP enrollees. So you can see some of the functions for online billing, presentment, monthly balances, payment history years, and data roll-up totals. So it's supposed to speed up premium payment processing, reduce call volume for the save on paper printing, consistent bills. It supports and promotes the exchange. For the carriers, Xerox has indicated that it speeds up premium payment processing, reduces call volume, saves on paper printing, mailing, handling costs, reduces staffing and administrative costs, and provides a consistent bill that supports and promotes the exchange. And then the advantages to the individual is that our system is available 24/7, and again, it's a consistent bill. So regardless if a person goes from one plan to another during an open enrollment period or some event, they would consistently get the same bill through the Xerox solution. They would be able to see if the billing is done by Xerox, they'd be able to see their history over however long they've been with the exchange. Basically, it standardizes everything. So again, their system provides online bill payment, multiple payment options, scheduling, recurring payments, automated notices in multiple formats, and are sent to the participants either by mail or by electronics. And I'm not going to go through all of the details here because there's quite a bit in these 13 pages. Xerox can handle late and delinquent accounts, late and follow-up notifications to delinquent account holders, and this would reduce the collection requirements from carriers. It reduces their call volume. They would be able to handle late and delinquent accounts, management of premium suspense files. So through this whole process, there are enrollment eligibility files that go back and forth between Xerox and the carriers that include the amounts that are billed and collected and sent directly to the carriers. They have flexible automated administration of grace periods based on the carrier's requirements and based on the new federal requirements. And they can account for adjustments, automated adjustment processing, retro term adds, billing files, and auto updating. Xerox has indicated that based on the last 16 years of running 5 private exchanges, that their platforms can reduce carrier internal administration of programs by up to 3.725%. In addition, 50% of all member inquiries are handled by the Xerox member services team on behalf of the carrier. And so a breakdown of how those administrative savings are broken out, are included on the top of page 5. So the Xerox model provides aggregated bills for individuals and families who might have enrollees in qualified health plans, Medicaid, and CHIP. The ability to track payments and life events within the exchange allows member services representatives, brokers, and navigators to provide assistance with switching health plans. Improve customer service and member retention by simplifying an individual's ability to view their bill and pay online or via a single dedicated call center for all enrollment and eligibility questions. The individual billing process allows members to establish recurring monthly payments via credit card or electronic fund transfers using automated clearinghouse, as well as receiving monthly statements for remittance methods of their choice. And I will note that CISIO has indicated that that a carrier or an exchange can accept credit card payments and can bill the individual for the credit card fee, because of course there's typically a 1%, 2%, 3% fee for that credit card. They can actually bill the individual for using that credit card, and it would not be considered part of the MLR cap as long as they have an option to pay in another way. So basically it's an added service to pay by credit card, and so if an individual wants to pay by credit card, they can, but they would have to pay the fee. It does not affect the MLR cap issues that the carriers, of course, are worried about. The Xerox model also provides the ability to have the exchange process payments on behalf of members. The members will also allow for more streamlined and accurate reporting to the appropriate agencies as required by the Affordable Care Act and associated regulations. So again, the Xerox solution allows for electronic paper billing, accepts multiple payment types, including credit cards, electronic funds transfer, automated debit, interactive voice response capture, check by phone, and paper checks. And they also track and reconcile all accounts and report payments to the appropriate entities, such as the health plans, the exchange, and the federal government. Payment receipts are aggregated from all applicable entities on behalf of individuals enrolled through the exchange, and it's conducted in accordance with the generally accepted accounting principles. So again, it all goes through the web portal. Individuals can pay by mail, through a call center, or through the web portal. The solution offers electronic presentment and payment solution that shows monthly balances and premium payment history, as well as a year-to-date roll-up online, providing necessary functionality for all participants in the exchange. Individuals have an easy-to-use retail-like experience to view and pay their invoices. The billing presentment component of the exchange solution offer a variety of payment options. And again, to note, even if we go with the option that Xerox perform the individual billing function, there will be some individuals that may want to pay the carrier directly, and that will have to be allowed and accounted for, and it is accounted for in the workflows that they've got, the workflows and money flows that they've provided. Other considerations, the driving dynamic of the exchange is to both help cover more Nevadans and to help drive comparative shopping to ensure consumers find the best value and encourage health plan competition. Enrollment will be a shop and compare experience. Allowing the health plans to perform the billing may compromise future comparative shopping and the pro-consumer value of the exchange in a variety of ways. And those include if the insurer performs qualified health plan billing, the incumbent insurer health plan will likely do the renewal billing. This may discourage a new comparative shopping process at subsequent open enrollments, as consumers will inevitably buy the renewal versus a new comparative shop and compare evaluation in the updated market. It will also make the consumer less aware of new products offered by the exchange. As a consumer experiences life changes during a policy year, including birth, deaths, moves, marriages, divorce, as that family composition changes, plans with a good rate for one family composition may not be ideal for a different composition. If an individual moves, a carrier that had an ideal qualified health plan for one service area may not be the ideal qualified health plan for another service area. And the consumer billing complaint issues will likely be directed to the billing entity. The exchange would lose an important level of health plan oversight and management and may expose consumers to an inconsistent level of exchange service and experience on a plan-by-plan basis. Overall, the branding of the exchange and the ability of the exchange to control a standard high level of member service will be diluted if the exchange cedes the billing function to the carriers. The long-term viability of the value-based comparative shopping experience will also be diminished. The Xerox team and Choice Administrators has a proven record to manage late and delinquent payments. They can deal with return checks, return payments, EFT and credit card, and managing premium suspense files. I'm not going to go into all of those details, but they have the ability to do that, and they've proven that they can do it in their other exchange products. And they can also adjust premiums based on life events, retroactive, employee, new hire and termination, birth, death, marriage, domestic partnership, etc. They provide a variety of financial reporting functions. With that, I'll move into the financial impact to the exchange. On page 11, you can see a table that breaks out the per member per month price with premium processing for individuals and without premium processing for individuals. So you can see the difference in price of $1.25 per member per month in 2014, and that will be paid for if the exchange were to choose to do individual billing. That would be paid for in that first year by the Affordable Care Act funds. In 2015 and 2016, you can see the difference in price is 92 cents and 40 cents per member per month. Based on our current estimated enrollment, and that estimated enrollment assumes that that we cover individuals down to 100% of the federal poverty level, that the difference in cost will be approximately $5.2 million over the 3 years, $2 million in 2015 and about $1 million in 2016. So from the carriers, we've received quite a bit of comments from the carriers. You saw the one public comment from Aetna. Additionally, several other carriers have noted their opposition to this, with one carrier supporting it. So on the opposing view, the carriers indicate that this is a duplication of services, services that they already provide. That for renewals, they indicate that they disagree with the branding notion of the exchange, and that the incumbent plan, who has taken on the risks all year, should be allowed to do the renewal billing. Anything but this will have a negative impact on the carriers, potential renewal, coverage lags, collection, and cash flow. I will note that as Xerox collects the funds from the individuals and then redistributes them, the current proposed methodology indicates that they would that they would redistribute those funds on a weekly basis. So the average float for funds that Xerox collects would be about 3 days. So the delay for the carriers would be about a half a week float that they would not receive. That's obviously a concern based on, they wouldn't have that money to collect interest on it. Xerox has indicated that they could do an everyday distribution, and so that would reduce that float obviously to less than a day. The insurers have indicated that pay as billed is unacceptable, that to payers. The vendor's proposed solution of telling employers to pay as billed is not a consumer-friendly model. That carriers have desired this for years for operational and cash flow reasons, but unless it is mandated, no employer wants to pay for retroactive terminations or changes. I believe that the Xerox solution allows for an individual to adjust if they get a bill, if the employer gets a bill that says, well, that's for the employer side anyways, but in any event, if the employer gets a bill that says they owe this amount for somebody that has already been terminated, they can adjust, they can right there change that person's eligibility to terminated status to adjust what they pay, I believe, and they can, Xerox can correct me on that one. Again, we talked about the cash flows. The carriers indicated that it will penalize established and committed carriers who have worked for years to develop relationships with consumers. And then for local payments, as a local carrier with all of our premium processing employees employed in Nevada, we currently accept a large number of cash payments at our local office, which is very popular with consumers and cost efficient because there's no credit card fees, debit card fees, or bank fees. We have heard, I think they indicated today that they can accept cash payments. And again, the system is required to allow an individual to pay the carrier directly if that individual would like. The supporting view from one of the carriers is that the efficiencies would translate to reduced state costs and ensure uniform billing. experience for the exchange and consumers regardless of specific plan enrollment. That if a centralized mechanism for these functions is not feasible due to carrier opposition, that carrier recommends the state develop clear and consistent standards for the health plans or vendors that will perform these functions to at least mitigate the potential for enrollee abrasion arising out of inconsistent practices and capabilities. With that, staff's recommendation is to determine whether the exchange should conduct individual premium billing functions through Xerox Healthcare LLC. And I do want to reiterate that it's important that we move forward with the decision on whether to do this because Medicaid and Welfare are waiting on our decision to determine whether or not they need to create their own CHIP billing function or whether we will do that for them.
All right, before we get started on the discussion among members, I just want to let those people here in Carson City and Las Vegas know that I am going to open this up for public comment before the board votes on it because this is an important issue for industry here in Nevada. So let me start it off with questions from Las Vegas. Does anyone have any questions or comments about the presentation on the individual premium billing?
Madam Chair, this is Leslie Johnstone. I have a question. 2 questions.
Please go ahead.
John, in your presentation, you made it sound as if qualified status changes could be entered directly by the carriers. I thought all of the status changes needed to go through the exchange web portal.
For the record, John Hager, I may have misspoke. The status changes that I was speaking of were the status changes that the employer enters. The status changes are supposed to go through the exchange. If Xerox were to do individual billing, generally everything will go through the exchange for any status change. However, there are times when carriers are notified of deaths or changes in status outside the exchange. A general change in status, the carrier should send them back to the exchange. In the case of a death, there's going to be a reconciliation process with the carriers, and the carriers will provide a notification of changes that they receive. Generally, it's supposed to go through the exchange, but again, in cases such as death or other items that they're notified, they would end up telling Xerox that there has been a change in status. I'm not sure yet what that reconciliation process might be. In experience from other in my past life, when we would do eligibility and enrollment, our entity was the system of record for enrollment and eligibility. Carriers would notify us of changes, and then we would have to reconcile it before that change was actually made. I'm not sure exactly how that reconciliation process would work. I don't know if Xerox has anything to add on that, or can correct me if I was incorrect on any of that statement. And they're coming up to the table.
Please identify yourself for the record again.
For the record, this is Joe Dela Cruz with Choice Administrators. No, Mr. Hager, you've explained that properly. So the intent is that we would reconcile membership with all participating carriers in the exchange. We also do anticipate and really would like to make sure and ensure that life events and changes happen through the exchange in that one single flow, coming through the exchange, feeding into the carrier. That is the ideal process.
Any other questions out of Las Vegas?
Madam Chair, this is Leslie Johnstone. I have a second question that maybe Chuck Duarte can answer. Is there an estimate of the cost for your system upgrade if you needed to administer the chip billing?
Charles Duarte, for the record, not at this time. I don't have a good number for you. I'm sorry.
Just to make the record clear on it, you already are doing that billing now, but you anticipate needing an upgrade. Is that correct?
That's correct.
Thank you.
Madam Chair, Lynn Atkins.
Yes.
I have a couple of questions also. So if if we didn't do the consolidated billing through Xerox, can someone explain to me how that would work? So someone would go on the website and purchase their health insurance, their vision insurance, and their dental insurance. How would they get the bill? Would that be something else they would have to log into to those carriers' websites? Would they get paper billing? I'd like to know how that would work.
For the record, this is Joe de la Cruz. It's one of the things that we are looking at for solutioning. It's a little bit unique right now, where especially if we go the route where one carrier may opt to have the exchange bill, one carrier may opt to go ahead and have the individual bill them directly. Our system can support either scenario. We fully intend to keep track of payment information and display it through the exchange, regardless of who collects the funds. So in the scenario that you've just mentioned, we'll say maybe the primary member has a commercial plan with a large health carrier. We would show the premium due. We would not collect as far as the amount to remit to the exchange. We would just show that there, possibly with some instructions on how to pay the carrier. For the CHIP program, that also would be another invoice item that would show the amount due, and that would actually be the remit to amount. So we would show pretty much like a pro forma invoice, and then actually this is what you owe the exchange with instructions on how to pay the additional premium to the other entity.
May I ask another question?
Certainly.
So I see on page 11 the per member price with premium processing, and this might be directed to Mr. Hager, and then without the premium processing. So would that amount be made up somewhere? So if we didn't do the premium pricing and the individuals were paying directly to the providers, would there not be a cost for that, or would that already have been built into the premium?
For the record, John Hager. So if Xerox were to conduct individual billing, as you stated here, as it's provided on page 11, there would be an increase in cost to the exchange in the per member per month price. With the recommendation that has been provided to this board from the Finance and Sustainability Committee, that price is built into, is to be charged to the carrier, assuming the board agrees with the recommendation. Theoretically, and based on what Xerox has indicated, there would be a reduction in administrative costs to the carrier, which should theoretically lower their administrative costs, which would lower the premium without. Let me back up. So theoretically, the increase in individual billing price that Xerox provides here should be offset by savings to the carrier. Xerox has indicated that difference is about 3.75%. I believe that's of the administration piece of the premium. So I think if you assume that a premium is, say, $300 and administration is 20%, so $60 that the carrier would save 3% of that, 3 to 4% of the 60. So you're looking at about $2 per member per month, and that would theoretically more than offset this PMPM pricing. Carriers are extremely skeptical of that savings dollar amount. They indicate that they think that the savings would only be pennies or dimes perhaps, and so I suppose that there is some discrepancy on the numbers. If you're Xerox, you think it's going to be higher, and if you're a carrier, you think it's going to be much lower. And honestly, I can't say what's right. I can tell you what Xerox provides with their 16 years of experience on the premium billing side. I do understand that the carriers are concerned that they still have to provide their call centers and their billing for all their plans that are offered outside the exchange. If we were a state like Vermont where every single person goes to the exchange, then it would make sense because nobody would get coverage outside the exchange, but that is not the direction that Nevada is going. So I can understand the carrier's skepticism, and I guess the real question is whether it would save the amount of money that it will cost us. One potential way to do it is to make it optional, and we still would have to work with Xerox to see if it's even possible from a contracting perspective as well as from an administrative perspective to make it optional. for, if one carrier wants to do premium billing through the exchange and one carrier wants to do it outside the exchange, we could potentially do that and see where the market ends up falling after a period of time. Unfortunately, it's very difficult to tell what that savings really would be right up front.
Any other questions from Las Vegas? Right. Dr. Klein, I know you're still out there. Do you have any questions on this at all?
No, I think Mr. Hager made a very nice presentation, so all my questions have been answered. Thank you.
Ms. Kerr, do you have any questions?
I do have one question. Looking at the carrier opposition, we are presented with potential scenarios, whereas with Xerox Healthcare we see actual showing of administrative cost savings, multiple consumer advantages and efficiencies. Were there any actual data produced by the carriers who are opposing this of how the scenarios they present would actually occur, or was it based on potential? I mean, what I'm asking is, was there any proof?
The carriers did not provide any specific data. What we received from the carriers, basically, the opposing view was for the most part copied from a comment, and you saw the comments from Aetna. And we received a couple of other comments that were basically identical, so they weren't included here because they were so similar to it. From the input that we received, all but one carrier, I think we had about 4 or 5 carriers provide comment. All of them were opposed to it, except for the one that provided their supporting view.
Mr. Hager, if I'm not, correct me if I'm wrong on this, the one supporting view, that company now has merged with another, so we don't know what their position is at this point?
That's correct.
Okay.
I would also like to point out, just so that we're clear, the contract that was ratified by the board and approved by the Board of Examiners included this as an option. So the $72 million maximum contract amount included this $5.2 million here, a little bit more because the numbers were based on higher estimated enrollment. So if we were to choose that Xerox will perform individual billing, it will not increase the contract amount at all. And if we were to choose that the carriers will do individual billing, then the actual cost of the contract would actually go down. We wouldn't change the contract, but the cost that we pay would go down. So it's not going to be any more than the $72 million contract.
Madam Chair?
Yes.
This is Leslie Johnstone. We're getting some feedback maybe from the phone.
Okay.
Could you...
I'm hearing that too here. Whoever's on the phone, if you could please mute your line, we can hear whatever's going on in the background. There's conversation going, or there we go. Thank you very much. Nope, it's still there.
Nope. Nope.
Madam Chair, question?
We actually have video of the moment where you lose control. Did you know, Darren, you were in the driver's seat?
I can't tell if that's feedback on us or what. Okay. Is there a way of turning the telephone line off for a minute? Or turning it down? Yeah, because what we're hearing is television behind. Okay, there. Thank you. No, it's still there. Apparently who was listening has probably walked out of the room. Dr. Klein, are you still on the line?
Yes, I'm on the line. I'm on mute, and I don't have a television on.
Yeah, I'll tell you. It is a distraction. I'm wondering if we disconnect the phone line, and Dr. Klein, would you mind dialing back in?
I'm sorry. You say again. You want me to dial back in again?
Yeah, we were going to disconnect the phone line to get rid of that distraction, and then, well.
Sure, I'm happy to call back in.
All right.
It's gone now. Okay, are you still with us?
I'm still.
Okay, then
I'm still here.
whoever had that going has now heard our concern. So thank you.
Well, I just don't like their choice of television programs.
Madam Chair, I have another question.
Yes, please.
Lynn Atkins. So on the fees, there's the administrative cost of the fees built into the premium billing, and then there's going to be a credit card processing fee. Are there also going to be fees for electronic funds transfer, check? I mean, what are the other fees that are anticipated, and are they based on the premium amount, or is it a flat fee?
For the record, this is Joe Dela Cruz. For the merchant fees, as Mr. Hager pointed out, there was some direction and again clarification on that. Was that merchant fee, which is a credit card fee, being passed to the individual, or was that to the carrier?
It would be passed to the individual.
Okay.
So the question we have, I guess, is that was it Ms. Adkins that had the question? That
yes.
That is there a fee for electronic funds transfer or any of the other options in addition to their normal premium?
Understood. Yeah, just wanted to get clarity on that point. No, there are no additional fees outside the administrative fees to process that check payment. So if they do an ACH, if they pay by PayPal, if there is a merchant fee or a third-party institutional fee that's there, then it would be passed to the appropriate entity. But from the Xerox standpoint, there is no additional fee beyond an administrative fee for processing payment.
This is Ron Klein. I'm sorry.
Dr. Klein, go ahead.
Chair?
Go ahead, Dr.
Thank you.
Klein.
And I apologize, I'm not hearing well all the time. If a person chooses to pay by credit card, are you saying there will not be an additional fee?
There would not be additional fee beyond the merchant fee. So the merchant fee, which is
beyond the merchant fee.
Yes.
So just in terms of just a real life experience, if a person is paying their monthly health insurance premium to the exchange, then if they choose to use a credit card, there's a 3% service charge or whatever it is. If they pay by electronic funds transfer, there's none, and if they pay by check, there's none. Is that the way you envision it?
Yes, that is correct. That's the way we envision it.
All right, thank you.
All right, I'm going to lead some questions here where I have some concerns on duplication of services, and then as that trickles down, a delay to the providers, that the doctors, the hospitals, the clinics that are expecting payment from the insurance companies. When we add another layer to that process, where that process is already being done by the carriers now, my concern is that you get time delays that then exaggerate the delays that providers experience already. And I think two of the doctors that serve on our board could probably talk about this better than I can. But when they bill for the insurance, they're not seeing that turnaround in 10 days. They're not seeing it in 20 days. They're not seeing it in 45 days. They're probably seeing it in 60 to 90 days. And when we add another layer to it with another cost to the individual, I have concerns with it. So I just want to open that part of the discussion up.
Madam Chair, may I speak to that? This is Ron Klein.
Yes.
I appreciate your concern. I don't think there's any relationship between when an insurance company pays a physician or a hospital and whether the exchange pays the premium or not. I think the insurance company looks to see if the member is eligible at the time the service is provided, and they pay the provider in some time period, which is never quite fast enough, and there are a lot of reasons for that. But I don't think that whether the exchange were to bill or whether the insurance company would bill, that would affect that. I think that the insurance company is going to look at and see if a person was eligible at that time and pay, and I don't think that those two are related.
Thank you.
Madam Chair?
Yes.
May I ask a question?
Certainly.
Charles DeWar for the record. I want to go back to the mixed coverage case scenario that Xerox presented. And did we get any consumer input on what they would like to see in terms of premium aggregation? I was wondering if any of the subcommittees received any comment from consumers. I know we got it from carriers, but not consumers. I haven't heard anything from consumers.
No, we've not received any comments from consumers on that. Now, there is a project out there called UX 2014 that got considerable input from consumers. I don't know if this mirrors the UX 2014 recommendations or not. Can you speak to that and how that matches? And then can you speak to your experiences with running the other exchanges and input from consumers about your aggregated billing for individuals?
And if I may, before we can...
May I interrupt for a moment?
Sure.
Lynn Atkins, I just wanted to, because the Consumer Assistance Subcommittee has not been asked to review any of this, and so I think therefore there has been no consumer comment. I just want to make sure it's been clear. It's never been on the agenda.
Yes.
And just to conclude my comments, I guess I'm kind of concerned with sort of these mixed coverage cases where a family may be having to or get bills from multiple carriers, pay the state premium directly for chip coverage for their kids. So it becomes a confusing situation for a family that's already probably having a hard time understanding what an exchange is and how they're going to purchase coverage. So thank you.
This is Madam Chairman LaVon Lewis.
Yes, LaVon.
Yes, I would just like to echo the comments made by the previous speaker. I think that for consumers to receive several bills from different entities would be very confusing. Certainly the population of people that I deal with on a regular basis would find that very confusing and very difficult to sort out. So I think as we deliberate, we need to take that into consideration.
Let me ask a question with regard to these mixed insurance policies that Mr. Duart's talking about. If a consumer gets a bill that has CHIP, it has the private insurance, and obviously nothing coming out of Medicaid, but there's an error in the billing, and the consumer contests it and short pays it, how does that get resolved?
Okay, so this is Joe Dela Cruz. I'll answer some of the questions here sequentially. I first wanted to address Mr. Hager's concern, and I'm sorry, in regards to the invoice for the individuals where there are multiple product types. So in our experience, it almost is ineffective to do multiple billings to an individual. In our case, in our experience, that would be an employer. So if you look at the idea of the consolidated bill for a multiple carrier program that employer is sponsoring, there's one consolidated bill that goes to that employer. There's not multiple bills from multiple carriers going to that employer. Thus, the success of a program such as ours is one of the key driving points and what really the linchpin that keeps that program together. So as we contemplate the idea at the individual level of having mixed product types where we have a commercial plan, in this family, they've got a commercial plan, a public program. You're looking at a very similar model that an employer currently sees right now in a multi-carrier program. A consolidated bill would essentially be the linchpin for that individual to really understand, have one single bill, easy to manage, doesn't miss a payment, doesn't pay short, falls short, and lose coverage, because that really that's the whole idea. Is we don't want anyone to lose coverage because of administrative issues. To the second point, as far as short pays are concerned, we actually do that through our reconciliation process. So the back end, we would treat a short pay, and we have this all the time. Someone would say, this person was no longer here, they'll write it on an invoice, and we actually then have to triage that. And that goes into our manual reconciliation process. So we do have workflows that deal with short pays, no pays, overpays.
What is built into the contract to protect the state and the consumer that there would not be a misappropriation of funds, theft, embezzlement of those funds coming into the exchange through this type of aggregation?
So there's a lot built into the contract. It's I don't know, 500 pages long. But the contract includes audit functions, both internal audit requirements and the requirement that they allow us to audit them, and we do have. We do expect to do that function. Additionally, they are licensed as a third-party administrator, and therefore the Division of Insurance can audit them, and I would expect that the Division of Insurance will probably audit them, at least for the first couple of years, and then after that, I don't know how regular that would happen. There are I don't think the service level agreements apply, but there are a lot of reconciliation reports and audits that I think would protect us and the consumers from that concern. I hope that answers your question.
This is Ron Klein. May I ask a question, please?
Yes, go ahead, Dr. Klein.
Yeah. Just to confirm, you did say, and again, if it's been said before, I apologize. I sometimes hear well or not. You did say that the exchange will be doing the billing for the shop exchange, correct?
That's correct. The Affordable Care Act requires that state exchanges do the billing for small employer for the shop exchange. Again, it's optional for the individuals.
So my point being is that if we choose to let the carriers bill, it's not that we can walk away from this process. We still have whatever the fixed costs are of the process of doing this. It's just a matter of whether we ramp it up or ramp it down. I mean, similarly for the health insurance carriers that John was referring to, in terms of them being skeptical about the cost that they're going to save. I mean, clearly, there are fixed costs and variable costs, and their fixed costs will be the same because they have to have those call centers. Presumably their variable costs will be less because there'll be fewer people at the call centers with fewer calls if we in fact do the billing.
I'm going to answer part of it. I think that if we do not do the individual component on this, there's a cost savings to the state in that BOSS contract of $5.2 to $6 million potential, and a lower per month per premium cost for the individuals. Now, from the perspective of the carriers, I think that Xerox has estimated what that cost is, but I think Ms. Kerr has put on the record that the carriers have not actually confirmed that estimate, so we don't know.
Madam Chair, this is Leslie Johnstone.
Yes, Ms. Johnstone.
I don't know who to direct this question to. We talked about credit card payments administered through the exchange. The merchant fee would be added on as a cost to the insured. Is that the same situation if the carriers do the billing? Do they pass on the cost of the merchant fee as an added fee?
For the record, John Hager, I'm not sure. Actually, Division of Insurance is shaking their head no. I'm going to ask Ms. Arnett to come up here and come up here and let us, just a second.
Good morning. For the record, Kim Everett with the Nevada Division of Insurance. To the best of our knowledge, they do not. I did lean over and ask the representative that's here today from St. Mary's to verify that question, and he said that their company does not. I'm not aware that any of the other carriers are passing on those fees, but we could make some inquiries for you if the board would like that information.
Thank you, Ms. Everett. You might want to stay close by just in case.
Madam Chairman?
Yes.
I don't know if I have a question or a comment, so I'll just see where it ends up. I think it sounds much easier for a consumer to get one bill, obviously, as long as it's clear and transparent, and they only have to make one payment to cover whether the family are on different policies or whether there's also added vision or dental. So that to me makes much sense. I think I'm still concerned, I think as the questions are coming, that that they're not paying twice for this luxury, and that they're not paying, it's not already built into the premium, as I'm assuming it is if there's not that fee based at the beginning, that if you pay the carriers directly, that there's got to be that built in somewhere, that they're not paying twice for it. I'm concerned about it for that instance, and also I know we've been talking about it in the bigger picture, wanting to make sure that folks who don't get the federal subsidy come into the insurance exchange and get their insurance through us. And I think every nickel or 25 cents or dollar that it costs extra a month to do that, I think makes it less and less likely. So I guess those are kind of my two concerns about it, understanding that I think it's far simpler and easier for the consumer, but I'm very concerned about these costs kind of just incrementally increasing and not seeing the savings in any other area. So I guess that was a comment.
Thank you. Are there any other questions by board members or even our non-voting board members? Yes, please.
Good morning. My name is Cindy Jones. I'm from the Department of Administration representing Director Molenkamp. First, my apologies for being late. I had an unfortunate calendaring issue. And some of my questions might be more elemental since I'm not regularly sitting on this board. Usually there are significant policymaker concerns about passing credit card fees on to Nevadans for a variety of programs over the years that I've been around the state. Have those
Madam Chair?
We can't hear her.
Could you ask the speaker to pull the microphone a little bit closer?
Sorry. Can you hear me now? Okay.
Yes.
Often when programs seek to pass on credit card fees to consumers, there's concerns by policymakers. Have those concerns been vetted or addressed? It's difficult. I understand the convenience that this would be to our citizens to have one bill, but it's difficult to make the fiscal decision without what would the offsetting costs be from the other side. For instance, the costs that would be associated with modifying the chip system or other potential savings to the state. Do we have anything separate from the carrier discussion of how much it would or would not save? Do we have any estimates of how much it would save the state in administrative costs? Yeah, I believe Mr. Duarte said he doesn't have an estimate on CHIP, but any other administrative savings?
We don't have the estimates for CHIP.
Are there any other state costs that would be saved by doing this besides the CHIP issue?
Not that I'm aware of.
Okay, thank you.
This is Marie Kerr. A couple of things. In terms of state administrative costs, I think one thing you'd say by having a much less confusing process for people who are who may not be as experienced purchasing health insurance is you'll get less call center calls, and you probably have an indirect savings there. And I think that if the carriers are not passing the 3% credit card or whatever it is fee directly onto consumers when they're billed, I'm assuming this cost is built into the premium and it's not just kind of a giveaway. So wouldn't SSHIX be doing the same thing if we are charging the credit card fee?
For the record, John Hager, so the contract was not set up to require that Xerox absorb the credit card fees. So if we were to do credit card fees and not charge consumers individually, then we would have to include that as a cost to the exchange separate from Xerox. I'm not sure exactly how to work that out, but we can make it work. And then would add that cost into our charge to the carriers, which would increase the budgeted rates that we have in the Finance and Sustainability Plan for the later agenda item. For the carriers, as Ms. Arnett pointed out, that they do not charge an extra fee for credit cards, that they absorb that price, but I believe there are many carriers that don't allow credit card payment at all. I could be wrong on that, and they try to discourage credit card payments because, as you know, if you're adding 2% onto the cost and they've got a 20% medical loss ratio cap, that is concerning. So I don't know how many people actually pay by credit card. We don't have that data. It is certainly convenient, but I would say in the case of large purchases, I mean, if you were to go to buy a car and you try to pay your down payment with a credit card, you might be able to pay a small piece of it by the credit card, but they don't want you paying because of the extra amounts. In the case of things like health insurance, where it costs a lot of money, they tend to discourage credit card payments. So it's not that it doesn't happen, but that I think it's discouraged. I hope that answers your question.
If I may ask a
Madam Chair, Lynn Atkins, I'm sorry, we're just getting some shakes of the head that most people are paying their insurance premiums by credit card from some of the brokers here, so just wanted to get that on the record.
Okay, and I'm going to open it up here in a minute to public comment too, so we can get some feedback from the carriers as well. But Ms. Jones?
Yeah, I apologize. And I believe I know the answer to this question, but just to follow up, if somebody were to pay with debit card or electronic check, then there's no charge, just as there is with some of our other programs across the state?
Joe Dela Cruz for the record. If there is a fee, a merchant fee or a third-party institution fee for the debit card, that would be passed on. So, we have a merchant fee for a credit card. If there is a fee for using the debit card, that also would be passed on. I'd also like to make a quick comment, if you wouldn't mind, just from our experience. As John had pointed out, the idea of having credit card fees, was not part of the contract. However, we also did not contemplate until we got some guidance here from CMS that credit card payments to the exchange, the fee would be passed on, that merchant fee would be passed on to the individual. It has been our experience that carriers do, within their MLR, account for credit card and merchant fees in their premiums. So it does become now the conversation about our premiums then 2 to 3% lower in the exchange versus what's in the commercial marketplace. So there are a few things. I think that's more of a policy decision, as Ms. Jones pointed out. For the record, our system is capable of doing either or. We are here to be flexible to what the exchange board would like to decide and require.
Okay, thank you. With that, I'm going to open it up for some public comment. And if you'll please identify yourself for the record, and if you're representing a particular entity or such, we'd like to know that too.
Thank you. My name is Gene Furr. I'm an independent broker, resident in Nevada. Just a couple of comments and or observations. $5.2 million, that's a lot of money. To take care of a situation that a lot of people handle right now without having a single billing system. In the marketplace, a number of people will receive multiple bills and be able to take care of it. I know that there's probably some that have never had that experience, but that's, I think, an item that we might want to try to get our hands around. How many people would we estimate in the individual market that would be receiving multiple bills? The other thing I noticed in the write-up here is there's indication of efficiencies that would reduce state costs, but we don't know what these efficiencies are. So how much of that $5.2 million would be reduced by these efficiencies? Can they be quantified? And these efficiencies, who would they be for? Would they be for insurance carriers? Would they be for Medicare? Or would they be for the Nevada residents who are going to be charged this per member per fee?
Thank you for your comment.
For the record, my name is Adam Plain. I'm with the Nevada Division of Insurance. I apologize. I don't mean to throw a monkey wrench out here, but I've got a couple items of concern to the division that I'd like to bring to your attention for your discussion. The first is Nevada Revised Statute 680B.0355 requires insurance carriers to make disclosure to insurance consumers if a portion of their premium is going to pay Nevada premium tax or Nevada state assessment or fees when those consumers receive their renewal billing. If the billing is aggregated, there's a concern about Nevada consumers receiving the proper statutory notification. Secondly, and this is kind of uncharted territory for the Division of Insurance in Nevada, but based on current administrative history and handling, The division currently treats any additional fee paid by a Nevada consumer for insurance as premium under the definition of premium levied in Chapter 679A. So if a consumer is charged a pass-through for credit card fees, there is the chance that that can be considered premium under the definition of insurance and would be subject the carriers to premium tax on that under Chapter 680B. In similar situations, like with a property casualty insurer, an auto insurance contract normally runs 6 months. Property casualty insurers will quite often give the consumer the ability to pay that premium on a monthly basis. But for the privilege of paying monthly, the consumer might pay, say, a $2 fee. That $2 fee is a quote-unquote other consideration and is subject to premium tax. In a life health situation, if the insurance carrier is using a third-party administrator and that TPA levies additional fees, administrative costs or something, those are considered vicarious fees to the carrier, and they're subject to premium tax. This is, again, uncharted territory because Xerox isn't necessarily acting on behalf of the carriers directly, but based on past administrative history, it's at least something to consider as you make your discussions and decisions. And I'd be happy to answer any questions on that.
Thank you. That's good information to have. Do we have any other public comment, maybe from Las Vegas?
Yes, someone's coming, Madam Chair.
Thank you.
Talking from the TV. Madam Chair, can you hear me?
Sorry, we can't hear you.
Can you hear me now? Can you hear me now?
Yes.
Hi, for the record, my name is Jack Kim. I'm with United Healthcare. And we've been watching and talking with Mr. Hager about this individual premium billing. We do have a number of concerns about it. I think if especially based on the comments that Mr. Hager had made earlier today, in that under the individual side, the carriers have to allow for individual premium billing. So we're going to have to allow for this individual premium billing anyway. So what you're really talking about is whether the second option is to do individual premium billing by the carriers and then add on the exchange to an individual premium billing. So and that raises concern because it's really a duplication of effort of what we're currently doing. We have the processes already in place, the people in place. We're doing it now. And so when you look at what we're doing now compared to what Xerox would do under this, they would just be building the same thing that we're building and already have in place now. And so the question then becomes really is the additional funds or the PM that's going to be charged. And you remember, that's going to be charged to everyone in the individual exchange or in the shop exchange. So that function and that amount will be paid by all the individuals in the exchange, whether they pay the carrier directly or whether they go through the exchange for that. So question is that worth the 2-point-some-odd million first year, 2-point-some-odd million second year, and then in the third year? It almost sounds like we're trying to put into bringing the system in place to correct a problem where I don't know how much of a problem really exists out there. The billing's been done by insurance companies for, at least my company, 30-some-odd years. The processes are in place. We also offer cash payments, especially in Las Vegas. It's a 24-hour town. A lot of people pay by cash. It's easier for them to come in and pay by cash, and so we offer that feature for them. So, we do have concerns that while the Xerox has made representations that we'll save all this money on administrative costs by reducing our claims billing process, I think that's based on the fact that on the individual side, they'll do all the billing. That's not going to happen because we have to keep all those processes in place. So what we're really doing is adding a second layer on top of what we already have in place. It doesn't cut down the expenses, and as Madam Chair, as you had mentioned, it just adds another level of administrative costs on top of what we already have. And, as we've been talking about the exchange for the last few years, we've been trying to pull out the additional costs on the administrative side that are repetitive, that are duplicative, that are probably aren't needed. And it sounds like in this case, though, we're going to add another $5 million into the health care cost that really doesn't need to be there. So with that, I'll be glad to answer any questions.
Thank you for your comments. Is there anyone else there in Las Vegas that wishes to comment? Doesn't sound like that. Is there anyone on the phone
Doesn't
line?
appear so.
Thank you. Anyone on the phone line that wishes to comment?
Chairwoman Campbell, this is Leanne Gasaway from AHIP. May I offer public comment?
Yes, you may.
Thank you. For the record, Leanne Gasaway with America's Health Insurance Plans. As echoed by my member companies, we have submitted some concerns both to the insurance division and to Mr. Hager about how the individual premium aggregation should be reviewed. And one thing that has not been mentioned, which is a primary concern to my member companies, is the reconciliation process with the advanceable tax credits coming from the IRS. Under the process that has been outlined by the IRS, the advanceable tax credit payments will be coming directly from the IRS to the insurance carriers. They will not be flowing through the exchange. And so there will be a reconciliation process that has to occur for anyone under 400% of federal poverty level who is getting tax credits subsidies through the exchange. So those have to be reconciled. To the extent that you have added the exchange as a third-party person in this transaction, it delays that reconciliation and complicates matters not only for short pay or no pay, but for the grace period that must be offered in addition to those that need to have notice requirements that have to come out from the plan, not from the exchange, that they are late or that their coverage has been terminated or that their coverage or that their payment is late. All of that has to be reconciled at the plan. And so to the extent that we're adding in kind of a third party into that transaction and process flow, it does complicate things for the health plan and delays that kinds of reconciliation and service for the member. So it's of paramount concern to us that the individual premium be paid from the actual enrollee to the plan of which they have enrolled in. I do see the value and benefit that has been talked about in terms of the consolidated billing for those who have multiple types of coverage, say a child who is on CHIP and an adults who are in private coverage. The challenge there is that we also want to have a direct relationship with those enrollees so that they understand that they are not in a government program, that they do have private commercial insurance, and that insurance's relationship is between the carrier and the member. And by having them have quote-unquote exchange coverage, they may confuse the matter of who they're actually getting their coverage through. And so, again, to allow the relationship to be more direct is something that we would desire, and I can't stress enough how the tax credits and the reconciliation for those who are receiving advanceable tax credits, we need to have those premium payments be easily transacted, and having an additional loop have to go through the exchange complicates that matter and adds administrative costs to the process for the health plans. And so we are under extreme pressure to lower administrative costs and to meet our medical loss ratios of less than 20% for the individual and small group markets. So we do not have a 20% administrative load for all products. It is much less than that. And we strive every day to make that more efficient, not less efficient. Thank you for my comments.
Thank you very much. Mr. Hager.
For the record, John Hager, just to one comment on that last piece about the MLR cap. The fees that are charged by the exchange are outside of the MLR cap. And so I certainly appreciate the need to make sure administrative costs are as low as possible, because that does affect the premium that's charged to individuals. So I don't want to take anything away from that part of it. But the fees that are charged by the exchange and the ability of the exchange to either do individual billing or not do individual billing is that cost is outside of the MLR cap. So again, it would increase the cost to the individual. It would not affect the 80%, 20% MLR cap issue.
This is Leanne Gasway for the record. Just to clarify, I wasn't talking about the administrative fee from the exchange. I was talking about the administrative cost that the plan will have to build into its process to do the reconciliation. That is part of the MLR administrative cost because the plan has to build that inside its own billing processes.
Yes, that's correct.
This is Ron Klein. May I ask a question?
Dr. Klein, yes.
Appropriate. And I should have asked this question before, perhaps either for Mr. Hager or for the gentleman from Xerox. Of the currently existing plans, what do other people do? What have other states done in this regard?
Joe, do you want to come forward?
For the record, this is Joe Dela Cruz. Dr. Klein, was that in regards to existing exchange programs? Because there are no existing exchange programs that we have throughout the country right now that are operational. In the current commercial market, we do not pass on those fees to any of the individuals that are billed. And actually, in the small group arena, because of the large...
No, I'm asking a different...
Okay.
I'm sorry, I'm asking a different question, and I cut out for a second. Of the other existing exchanges, in terms of direct billing versus carrier billing, what currently exists? And for those that do the exchange billing, are some of the problems that people have mentioned, are those, in fact, do those occur, or are those easily solvable?
I can speak from our experience, looking at the marketplace from our side, that states are actually contemplating the exchange bill versus the carrier bill. The representative from AHIP was absolutely correct. There are concerns in the individual area with regards to CMS paying the subsidies directly to the carrier, how that reconciliation process will happen. However, we do find that states are contemplating the larger piece, which is how do we handle the shop billing. So we see more conversation or narrative or solution around the small group billing side of things versus any kind of in-depth conversation right now around individual. To be honest with you, this is probably the most lively conversation we've witnessed so far around this area.
I guess if my math is correct, if it's an additional $2.5 million per year and we're contemplating 200,000 exchange members, if I'm doing my math right, then that additional charge of $5 million is $1 per member per month. So although we want to keep our costs as low as possible, it sounds like when you put it in that perspective, it's a much smaller number.
For the record, John Hager, the cost on a per member per month basis is $1.25 for 2014.
25 cents.
And again, that part will be paid for by the Affordable Care Act. In 2015, it's 92 cents per member per month, and in 2016, it's 40 cents per member per month.
And is that paid by the Affordable Care Act every year, or did you just say just in 2014?
So in 2014, the Affordable Care Act, Section 1311 grant funding pays for the entire $1.25. In years 2015 and 2016, if an individual is subsidized by the advanced premium tax credit between 100% and 400% of the federal poverty level, then that entire amount would be paid for by the advanced premium tax credit. If they are not subsidized, then the individual would pay for that amount.
So just to underscore the point you're making, it sounds not that we're not all concerned about the federal budget deficit, but it sounds like the additional administrative costs of us doing having the exchange do the billing is really first paid by the federal government in large part in the first year or entirely in the first year, and then really in majority in some of the out years.
It appears that way, yes.
Thank you.
Do we have some other public comment here?
What does he say?
Jim Mullen with Delta Dental Insurance Company. To answer first Dr. Klein's question about other states, we're very active in California. The California Exchange Board has made a recommendation to their board for the carriers to conduct the individual premium billing for many of the reasons that Mr. Hager expressed of those who are in opposition to the exchange doing so. And I think as Ms. Gasaway has also pointed out, on behalf of standalone dental carriers, there's a very small part of the essential health benefit package for pediatric dental, and that would also extend to pediatric vision. And so we would be in support of premium aggregation on the basis that, as has echoed some of the comments here from Mr. Duarte and others, a standalone dental carrier is allowed in the exchange if it is certified to be there. But the premium on a child-only benefit on a monthly basis could be as low as $20, $25. A heavily subsidized individual at 80%, we're looking at a less than $5 monthly premium amount. And so the economies of scale for an individual dental carrier or vision carrier to go after those very small monthly amounts, perhaps causing the consumer to incur yet another credit card charge should they choose to pay by that means, it only exacerbates these things that we've been talking about, these fees. So the benefit of the aggregation is that essentially it is one bill and it can be paid at one time. One other point is I agree the reconciliation may be problematic. I don't know if it's been determined that the subsidy will be paid solely on a monthly basis. I believe that it will from the IRS. But I think that many insurance companies operate by having these installment payment periods, which can be either annual or biannual or quarterly payments, which would lessen the usage of credit card payments so that the fees that get applied to that are not exacerbated by using it 12 months in a course of a year. I don't know, though, how that does cause problems perhaps with reconciliation, because if the federal government's paying on a monthly basis, there may just be problems in reconciling that. But for the reasons stated, on behalf of a standalone dental carrier, we would be in favor of the exchange doing premium aggregation in the individual exchange. Thank you.
Good morning.
Madam Chair, Dwight Mazzoni.
Just a moment. We've got some other public comment here in Carson. Please.
Good morning. Alicia Caffaretta with Nevada Advocates for Planned Parenthood. Usually many times I have to start my testimony by clarifying that I am not an attorney, so I can't practice law. This morning I'll clarify I'm not an economist either. But I think that one of the challenges that you have in making this decision is that there are so many working parts in terms of deciding where this cost is going to live. As has been pointed out, insurance carriers already have to be able to bill individuals directly. And in fact, you can buy individual insurance today and get an individual bill. So there's not an additional cost to insurance companies to set that up. So that is something that exists already. And the reconciliation of the tax subsidies is also something that's going to have to be taken care of in any case, whatever decision you make about aggregating the billing. One of the number one guiding goals and principles of the exchange is to make it easier for individuals to buy insurance, and as well as to recognize the market and business concerns. And it certainly will be easier for consumers to buy insurance if they have one bill. Particularly if they have a mixed family situation where there's some on CHIP and some on Medicaid and some on a private insurance, or a mixed situation where they're buying health insurance and a standalone vision or dental product, but also over their lifetime. At Planned Parenthood, we see we have 5 health centers. We see 26,000 clients a year, and over the years they get married, they have children, and so they are adding and subtracting products. And over their lifetime, it would be much easier for them if they were dealing with the exchange. Nothing precludes the private insurance company from having a relationship with their clients. And I know I have a relationship with my insurance companies. They all send me newsletters and helpful hints. And so certainly that's a good business practice that will continue regardless of the decision you make. But one of the things that hasn't been talked about is if you, this idea that you could possibly save $5 million, what you really would be doing is externalizing that cost to the hardest hit lowest income families. You would be, instead of making it easier for them with one bill, you'd be having people driving all over town, dropping off cash payments all over town, dealing with finding stamps or writing checks. A lot of people who use certain banking institutions get charged on a per check basis. So you're just taking that cost and putting it on a family that is already obviously struggling desperately if they qualify for a subsidy or a government program, and just adding greatly to their burden. So I hope you haven't heard a lot from the consumer side. I have been talking to other consumer health organizations. They're very concerned about these families that are not in the system now, that we do everything in our power to reduce the barriers, to reduce the cost, to reduce the challenges to those families and get them the care that they need. The only way you actually get the savings in healthcare is if you get these people into programs so they can start getting the preventive care and the upfront care that they need. And you've got to do everything you can to reduce the barriers to them if you want that to happen. So I appreciate your time.
All right, comments from Las Vegas?
Madam Chair, Dwight Mazzoni for the record.
Thank you.
Speaking on behalf of the producers, brokers, whatever terminology you want to use. First of all, in the general market right now, we use typically either automatic bank draft, debit card, or credit card to pay for individual health plans, whether there be dental, health insurance, or vision insurance. Anything that's out there can usually be set up on one of those modalities. Very seldom do you get someone who wants to pay or pays quarterly or semi-annual or annually, although it does happen. That could be a possibility. One carrier in particular, Anthem Blue Cross Blue Shield, if you write a family, you might write a family with 4 members, and there might be one member is a preferred, one member is a super preferred, and one member has a 25% rate up, and the other member has a 20% rate up. They consolidate or aggregate that bill, so you get one bill with everybody on it, even though they have different amounts. So I think most of the carriers probably would do the same thing, is my understanding. I don't think it's going to be as big of a problem. The other thing is, and I appreciate the comments recently made about what's going to happen in the future, but at least under the current law and the way things are going at this point in time, 1/1 of 2014, there's no more pre-X. So until the carriers can tell me what they're going to do as far as somebody who has an insurability factor, if that is part of this conversation, I don't know how we can even discuss this until we know what that law is going to look like and what the carriers are going to do about someone coming in. Are there going to be different rates based upon that insurability factor and everything else? That has not been addressed, and not heard anything from the exchange or actually from any of the carriers at this point in time. So I'm concerned. My concerns are much the same as has been talked about. My concern is we make this thing so convoluted and so difficult that even regular normal people like myself, if that you could call me normal, would be able to understand what's going on when they get a bill. I think the carriers need to be definitely involved. I think it would add an unnecessary layer if everything had to go through the exchange in order to get to either the carrier or get back to the insured. We want to try and simplify this so we can reach as many people as possible. And I don't know that we're doing that by adding all these layers and all these different fees. As far as fees are concerned, I am not aware of any individual products, and I may be wrong on this. I can think of maybe Assurant does, charges a monthly fee for a plan, but it's not a credit card offset fee or anything like that. And some carriers on the group side for the shop groups may charge a billing fee or a monthly billing fee for each group. I think that's kind of going by the wayside nowadays, but I know that there are still carriers out there that are doing that. So to try and simplify this, I think we need to keep the carriers involved and have things segue from the carriers either if they have to go back or if there's a reporting criteria for it to go back to the exchange and let the exchange reconcile from their end of it versus trying to run everything from the exchange back out to the carriers and back out to the public. Thank you.
Thank you. You know what I'm going to suggest is maybe we take a 5-minute break right now and then come back and see what the pleasure of the board is. So if that's all right with you, let's go off the record for a few minutes, take a break, and we'll come back.
I don't know.
We're still in break.
Is anybody back yet?
We're still in break.
Okay. Is this John? John, John Hager, are you available?
Yes, sir.
Are you on the call?
Yes, sir. Go ahead.
I can answer this question publicly, but it's an easy question. Does Xerox have the ability to accept cash payments? Whoa.
We'll ask that when we'll ask that of them when we come back.
Wait, let me go inside. The Thunderbirds are practicing where I am, so it's a little loud. Hold on. All right. Sorry, say that again, please.
All this is going over the internet, but we can ask them those questions when we get back.
Okay. Yeah, I know it's not a private conversation. I don't want to waste anybody's time if it's a simple yes or no.
No, I think it's important that it's put on the record.
Okay. I'm in Atlantic City. There's a big air show coming tomorrow, so the Thunderbirds are playing outside my window.
All right, let's go back on the record. Yeah. All right, thank you, everyone. During our break, I was talking with our executive director, and one of the questions I had for him was with respect to a question that we had early on in this discussion. And Lynn, this addresses your comment as well, too. Since we're talking about a cost that would be passed on to a consumer in this process, my question to Mr. Hager was, what would happen if the board asked the Consumer Assistance Committee to take this up on their agenda August 29th to get some feedback from consumers as well as from the carriers, and then ask that subcommittee to make a recommendation to the full board for its September meeting? It seems to me that we've had input from everyone but consumer groups with respect to this one question, and for me that's a big hole in the discussion. I don't know, we might want to have some of our participants come up and let us know if doing that, and if Lynn, as chairman of that subcommittee, if you would be agreeable to that request. So if I could have you.
I think that sounds like a great idea. I have two comments about that, though. One is I think the question, I still think I'd like to see, and I don't know if anyone else here would like to see some more numbers and how this is going to impact consumers and if there's going to be a savings somewhere else. So I don't know if that's enough time for staff to get together a few more numbers. My other comment is our committee meetings are really long. And there's lots of public comment. So I am completely okay doing it. I think we need to extend the meeting time a little bit to allow for public comment. So, Mr. Hager, what are your thoughts about that?
I absolutely agree. I imagine that will probably be a 4-hour committee meeting. So we will. It's currently scheduled for 1:30 p.m. I think we'll try and move that up to 1 p.m. and schedule it from 1 to 5. It'll be a long afternoon.
That would be fine. And do you think the staff would be able to have a few more details on numbers and impacts and savings and costs and those sorts of things?
We will work our magic and try to come up with information that you need to make your decision. I can't guarantee you that we can get you everything, but we'll do our best to get as much as possible.
And if I might request, Ms. Jones, since you're here from the Office of Administration, you had some good questions with respect to cost savings. If you might share some of those questions with John so that we can kind of nail down as much as we can as quickly as we can. All right, and at Xerox.
This is Jennifer Wadham. I'm
I know
Solution
time
Manager.
is money, so.
Yeah. This is Jennifer Wadham. I'm the Solution Manager for Xerox, and we had planned on being here on the 27th anyway, so we can stay till the 29th and do the presentation for the consumer community.
Well, and we had asked for you to do the presentation of what it would look like online, so it seems kind of appropriate that all of this happens at the same time.
Absolutely, and we can do the presentation of what a premium payment experience would be for a consumer.
Okay.
Ms. Wadham, for the record, John
Clarify
Hager.
the 29th. Said that.
Consumer assistance is on the 29th. So she was referring to a meeting that we're going to have internally on the 27th, and they will stay around in town to do the presentation on the 29th and then discuss this item in depth, I'm sure, again, at the consumer assistance meeting, which will start at 1 p.m. That would be, the decision of the committee would be a recommendation to the board, and then the board would decide that on September 13th at its September board meeting. So just to confirm, Ms. Wadham, we can move forward with our implementation of the BOSS solution, and this will not impact it if we wait till September to make this decision.
That is correct. We have plenty to work on until September.
Okay, but if we go any further than that, then that could become an issue.
Yeah, if we go further than the middle of September, we need to look at the full schedule. But we definitely can wait till September 13th.
Okay, and then if I could get, is Mr. Duarte here? Oh, he had to step out. Okay. I believe Mr. Duarte said that we could delay. The other issue is whether or not Medicaid and welfare build a CHIP billing system. He has indicated that he got some numbers at the break, some rough estimates for the cost of the CHIP billing system is $3.4 million. 90% of that would be paid for by the federal government, so the state general fund would pick up $340,000 of it. That's a very rough estimate. He said it could be substantially less depending on how they build it. So just wanted to throw that out there. Again, very rough estimate. He also indicated at the break that that we could delay it. The biggest issue was budgeting, although I believe the programmers are hot to trot to get on this as well. Again, any delay after further than September, and I'm sure the programmers will be disappointed that we're delaying this again, but just to confirm, Mr. Duarte's coming up, that we could delay this decision to September. It will make it a little more difficult to implement the CHIP billing, but that it can be done with a delay to September.
Charles Duarte for the record. It's really not necessarily an IT issue, it's a budgeting issue. And so as John and I discussed in the break, perhaps one way to do it is for both of us to build it in our budgets for agency requests, and then one of us take it out. So I discussed that with some representatives from the welfare division as well, and we'll be talking more about that plan of attack next week, but I think that's the tentative plan.
Great,
right
thank
now.
you.
And then if I might, if those that want to participate in this meeting on the 29th, if you have written comments and information, I would encourage you to get that to Ms. Atkins through Mr. Hager as soon as possible. I think there's one issue that I would like at least to have some conversation on, and that's how do you deal with that reconciliation process. If the IRS is giving the subsidy to the insurance carriers, and if the board decided to do the aggregated billing, are we creating issues there for not only private sector but for the public sector? And just let's walk through that process to make sure that we've at least explored it. So if Ms. Atkins, does that suggestion work for you then?
Yes.
Okay, and how do the rest of the board members feel? Do you think this might be a likely solution for us by putting it off for another 30 days and having the Consumer Assistance Committee take a look at it?
LaVon Lewis. I think that is a good idea. We had certainly kind of, I had certainly considered that it needed to be reviewed by some committee, either Finance and Sustainability or Consumer Assistance. So I think Consumer Assistance is actually appropriate for that review. And putting it off for a month is certainly in the best interest of making the best decision.
Okay.
Ron, I agree with the chair. I think a lot of positive and negative issues on both sides, and thinking about it for another month is a good idea.
I'm going to ask our Deputy AG, do we need a motion to move that back to the subcommittee, or is the conversation sufficient for the record?
No, I mean, I think that the conversation will go ahead and the subcommittee knows what's going on, but you probably just need a quick motion to table this to your next meeting, this agenda item to your next meeting, and then that would take care of it.
Thank you. I appreciate that help. All right. Based on the recommendation of our Attorney General, then, is there someone that would be willing to make a motion to table this until September 13th after the review of the Consumer Assistance Committee?
LaVon Lewis, for the record, so moved.
Thank you, Ms. Lewis. Is there a second?
Dr. Ford, I second.
Thank you, Dr. Ford. All in favor of the motion?
Aye.
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 Aye. Any opposed? Thank you. We have a unanimous decision on that. Next item on the agenda is item number 8, which is the review of Nevada's Level 2 Establishment Grant that was submitted on June 28th. Mr. Hager?
For the record, John Hager. So this review of the establishment grant submitted June 28th is provided for the board. The establishment grant was submitted in the amount of $50,016,012. We expected to have a notice of grant award probably Tuesday or Wednesday. I don't think we've gotten it. We've not received it yet, but it should be sometime soon. We don't expect, based on our negotiations for the budget, we don't expect the amount to change. I would not be surprised at all if we got the amount that we've requested, but of course, you never know until you actually get that award. With that, I will turn it over to questions if there are any. I would like to point out that the enrollment figures that were provided in the grant have changed again, and I think we've settled on enrollment figures you'll see in the Finance and Sustainability Plan. But based on the administrative abilities of the exchange to request money or not use money, the changes to enrollment will not significantly affect our ability to get the funds that we need through 2014. So while there might be some slight changes going forward, it's not significant enough to worry about. We have the ability to request a little bit more based on this amount or not use it, of course.
Do we have any questions for Mr. Hager on the establishment grant? All right, thank you. That brings us to item number 9, which are action items coming from the advisory committees. And first up is Finance and Sustainability. So, Ms. Lewis?
Well, LaVon Lewis, for the record, the Finance and Sustainability Committee has looked at all of the attachments that are included, and they have presented a report for the board's review and approval. And we have made recommendations that are included in the information provided to the committee. For funding options, we are recommending that we fund the exchange through a per member per month assessment on carriers based on enrollment within the exchange. And the committee looked at several options for doing this depending on what decisions are made by the state in terms of whether or not they accept what happens with the determination regarding Medicaid eligibility. And perhaps Mr. Hager would like to make some further comments on that particular recommendation. And we would like to get them approved, I guess, not all at once. We will do them individually because the second one will probably have some additional discussion. So we are moving, actually, that we fund the exchange through a per member per month assessment on carriers based on enrollment within the exchange.
For the record, John Hager. So just to review some of the items that the committee looked at for the per member per month assessment on carriers on the products sold within the exchange, we looked at long-term sustainability. We looked at risk to the exchange. A majority of the per member per month fee is the payment that we make to Xerox Healthcare Solutions to do the business operations, the financial management, the billing, the shop exchange, premium aggregator, all of those functions. The majority of the functions are done by Xerox, so a majority of that per member per month fee is paid to Xerox on a per member per month basis. The rest of that include our fixed costs, which include salaries, rent, supplies, the various things that we need, consultants, other contracts that we are required to use to transact, to make sure there's proper oversight and our business is done properly. There were short-term viability concerns and operational reserve concerns in the and because this goes toward the per member per month fees, I'm going to talk about how they were constructed here. They're slightly different from the plan that was approved by the committee, and I want to explain why. The committee expected that we would have a 30-day operating reserve, and we have done that long term. When the initial policy decisions were made, we did not have a decision on whether the Affordable Care Act funding would pay for 2014 operations. Since then, the operations in calendar year 2014 will be paid for by the Affordable Care Act. Because we don't truly know what enrollment will be, it's a guess. I think we've got some decent assumptions, but again, there is no historical data to really nail down what enrollment will be. So there are a lot of assumptions. So to mitigate that, we have built the rate in 2014 to be equal to that amount required to, number one, pay for navigators that are not cannot be paid for by Affordable Care Act funds, and number two, to build us a 60-day operating reserve for that first year. And then, of course, the long term is a 30-day operating reserve that basically equals the amount of our expenses. So you shouldn't see a significant change in the operating reserve from one year to the next. So then the key was to determine what those fees should be in the middle years, and we basically wanted to gradually step that up. You can see the chart. If you look at page 7 of the Finance and Sustainability Plan, which is toward it's in attachment B, you can see how we stepped up that rate, and we can go over it again if you'd like after this. But so we basically build a fee that is the same regardless of whether the state chooses to expand Medicaid or not. That way, if the decision to expand Medicaid is not made until the end of the legislative session, we have set up a fee that will create the reserves that we need. Based on the higher enrollment, you'll have higher costs, so the reserve would be less than a 60-day reserve. So we tried to set up, if in the scenario where eligibility is at 100%, we tried to create a 60-day reserve. If it's at 138%, costs are lower. We build a 60-day reserve. If you're at 100% federal poverty level for our lower threshold, our enrollment is higher. Therefore, our costs are higher. Therefore, the operational reserve actually ends up being slightly less than 60 days, but it's absorbed by that higher operational reserve, and then we step up from there. So that's kind of what we did. We think it made sense to base it on our operation reserve, and then gradually build that to draw it down to 30 days. So that's how we came up with the per member per month assessment. Of course, the recommendation was separate from the amount. It was simply to charge carriers a per member per month assessment. A couple other things that we looked at, legal and regulatory. We are still in the process of determining whether the board can create regulations to charge the fee, or whether that has to go to the legislature in statute. So we're looking at that. We looked at the medical loss ratio, and SSHIX has indicated that the fees that are charged by the exchange are not included in the MLR cap. And then we also looked on the tax on exchange fees, and the board has already recommended that if we determine that the fee will be charged by the carrier, that we submit a BDR to exempt the fees that are charged by the exchange to be part of that, so that the carrier is not charged a premium tax on top of the fee charged by the exchange. So those are some of the issues that we dealt with in creating the recommendation. The committee dealt with in creating the recommendation to charge a fee to carriers based on a per member per month basis on enrollment within the exchange.
All right, so the discussion that we have before us right now is to fund the exchange on a per member per month assessment that goes through the carriers. We've got examples of what we think it is based on hypothetical enrollment figures, but those numbers could change depending on what the enrollment is. Is that correct?
So yes and no. The numbers are based on it's hypothetical enrollment, and so we've created our budget and we've divided it by the enrollment, and we've come up with the rate that we're going to charge. That enrollment could change. If the enrollment changes, at that point we can't change the rate. So the rate is what it is. But we feel that we've got enough operational reserve to absorb potential changes in fairly significant changes in enrollment. So we wouldn't change the rate for the current year. Now, the rates that we provide for outer years, we would end up having to change those if enrollment varies significantly. But for the first year, the $440 per member per month is a pretty solid number. Let me find. I lost my page.
Page 7.
There it is. Yes. So if the exchange does individual premium billing, the charge would be $4.40 per member per month in 2014. If the carriers do individual billing, it'd be $4.20 per member per month. You'll note the 20-cent difference is not that $1.25 because that $1.25 is paid for by the ACA grant funding. The difference in the 20 cents is because the cost would be higher, so therefore it would take more money to build up a 60-day operating reserve. So that's only the difference in the operating reserve. You can see the differences in costs are a little bit bigger, and then they end up being about 40 cents per member per month in the outer years, as provided in the previous discussion.
And do you and Ms. Lewis anticipate that there'll be kind of an annual review of this, and then the board will approve these fees annually based on what real numbers are then?
Absolutely.
Okay. Do we have any other discussion?
I just wanted to comment that the committee considers that the exchange has to operate like a business, so that they have to have fees that cover the costs of operating the exchange.
Thank you.
And this will accommodate that.
Okay. Are there any questions, any other questions by board members, or is there a board member that would like to make a motion to approve?
This is Ron Klein from Las Vegas.
Yes, Dr. Klein.
Yeah, I know that Mr. Hager and I discussed briefly whether it was possible to assess the per member per month fee on subsidized members alone, whether that was legal. And then the idea behind that would be so that a non-subsidized person purchasing a health plan inside or outside of the exchange would pay the same price, as opposed to being at a disadvantage if they purchased it within the exchange, since they have an additional $4.50 per member per month price. And I'm wondering if, I know that Mr. Hager was questioning CSIO about that. I'm wondering if he received an answer.
Yes, we have asked CSIO whether or not it is if we are able to, number one, charge an individual a fee as opposed to charging the carriers, and we can do that. The question is whether or not, if we charge an individual, whether or not that would be included in the calculation for the advanced premium tax credit. And then the next question was Dr. Klein's question about if we were to charge an individual, could we only charge it to those between 100 and 400% of the federal poverty level, which would be entirely paid for by the advanced premium tax credit. We've not received an answer to either of those questions, so we're still waiting on that. If we get that information and it is and we could do that, we would obviously come back to the board to clarify, to make sure, or perhaps the Finance and Sustainability Committee, depending on the board's pleasure, to discuss that further. But
I think it's worth reiterating what you just said, that if that was legal and if that was acceptable to the board, then the entire per member per month fee would be paid for by the federal government.
That's correct. And so we'd have to revisit that. at this point, we'd like to move forward with the current recommendation based on the current information that we have, so that we can move forward with our budget. But we would certainly bring that information back to the board if it changes anything. The other item to consider is it's always a possibility to change that for future years, for instance in 2015 rather than 2014, because nearly all of the expenses of the exchange are paid for by the ACA grant funding in 2014. So it's not something we'd have to do for 2014, but we could do it for 2015 if we decided.
Any other questions?
Madam Chair, I just would like to make a comment regarding the potential for only having subsidized insured pay that fee. You might want to verify that allowability with the federal government. In my dealings with the federal government in a variety of programs, they tend to have an equal treatment standard where you can't treat those being federally funded different than those that aren't. So that might be an issue you may want to explore too on that.
Yes, and that was our question that we asked of the federal government. Can we do it?
Okay, so you've asked the federal government that. Okay.
Yes. These questions are questions for SSHIX, for the federal government.
Okay, thank you.
And this is Ron Klein again. Just to be real clear, I'm not trying to pick on folks who are receiving a subsidy from the federal government. My primary concern is that that we want to be competitive within the exchange for those people who are not receiving a subsidy. So if you're paying, let's say $4 and you have a family of four, you're paying $16 per month additional costs inside the exchange, so about $200 or about $200 more expensive per year if you purchase it inside the exchange for a family of four than if you purchase it outside, which, as Mr. Hager and I have discussed, a person would go on the website, find the policy, and then go outside the exchange and buy the same policy outside of it, or a near identical policy. So that's my primary concern, is that we remain competitive for non-subsidized individuals.
Thank you, Dr. Klein. Any other questions or comments? What's the pleasure of the board?
Madam Chair, LeBron Lewis, for the record, I move approval of this particular recommendation from the Finance and Sustainability Committee.
Okay, there's a motion by Ms. Lewis. Is there a second?
Marie Kerr, second the motion.
A second by Marie Kerr. All those in favor of the motion?
Aye.
Aye.
Aye. Aye.
Any opposed? Thank you. The decision is unanimous. Ms. Lewis, item number 2.
The second recommendation from the Finance and Sustainability Committee was that we partially fund the exchange through a general fund appropriation in an amount equal to 25% of the estimated increase in premium tax revenue created by insuring through the exchange those who are currently uninsured for fiscal years 2014 and 2015 only. The board considered some staff estimates of the increased number of people who would be insured and therefore would generate some increased premium tax. However, I understand there has been some additional. Mr. Hager, do you have some additional information on that?
Absolutely, for the record, John Hager. So on page 9 of the Finance and Sustainability Plan, we talk about the general fund appropriation. The enrollment figures were updated since the meeting with the Finance and Sustainability Plan. We came up with some final enrollment figures with the Department of Health and Human Services. So you can see the changes. We expect that so in fiscal year 2014, we expect that newly insured individuals would generate $5.6 million in premium tax collections, and in 2015 we estimate $12.5 million of premium tax collections. The first year is is a little bit less than half, and the reason is, number one, because of enrollment, and number two, because the federal fiscal year ends June 2014, so it's really only half a year. Based on the recommendation of the committee to to request a general fund appropriation in amount equal to 25% of the estimated increase in premium tax revenue created by insuring those that are currently uninsured. That would create about $2.8 million for the exchange in calendar year 14 and $1.7 million in calendar year 15. And that equates to about $1.62 per member per month the first year and 78 cents per member per month the second year. And the reason why it's less is because we would only get that through the biennium, which ends June of 2015. And there's some slightly different numbers depending on whether Medicaid is expanded to 138% or not. So a couple of things have happened since then. Since the committee made its recommendation, SSHIO switched its analysis of Affordable Care Act funding. As we discussed, we will receive the Affordable Care Act funding through December of 2014 in the amount of some $12 to $15 million, depending on various decisions on individual billing and enrollment. The funding of the exchange in that first year is not in question as it was before that. Additionally, when we went to the Board of Examiners to approve the Xerox contract, we were at the table for some 30 to 45 minutes answering questions about the state's liability for the contract and the out clauses and what happens if funding goes away, what happens if the legislature changes its mind on the exchange. One of the comments from the governor, you may have read it in the paper, he said, I will not be supportive of taking general fund money from education, that the exchange should stand on its own merits. So if the board chooses to go forward with this recommendation in its agency request budget, it appears almost certain that it will be taken out at the governor's requested budget. He was very clear, said it several times, that the exchange should stand on its own merits. One final note, I talked about the 60-day reserve earlier. By providing that 60-day reserve through the rates, if enrollment should change, again, we should have sufficient funding to be able to absorb any major changes in enrollment that we don't expect. And so between that reserve that we're requesting that first year and the Affordable Care Act funding and the comments by the governor, the board should consider all of that when taking into account the committee's recommendation. And with that, I'll be happy to take any questions.
Do we have any comments or questions from the board to Ms. Lewis or Mr. Hager?
Assuming we did the appropriation, are we artificially subsidizing individual premiums, or maybe just premiums, through taxpayer dollars? And second question on that line, is there any statutory preclusion to that type of cost shifting?
So if you are taking general fund dollars to pay for the functions of the exchange, you are using taxpayer dollars to pay for the functions of the exchange. Again, the functions of the cost for the exchange will be based on the board's previous decision to fund the exchange through the assessment on carriers, which will mean that goes into the subsidy. We are using Nevada taxpayer dollars to subsidize premiums in that regard. Keep in mind that a majority of our expenses are subsidized by federal taxpayer dollars. And I didn't quite get your second question.
Is there any statutory preclusion in Nevada to that type of cost shifting?
I'm not aware of any statutory provision that prevents us from getting a general fund appropriation. However, I will point out that to get a general fund appropriation, it has to get through the governor's budget and the legislative budget process. And so whether or not we get that funding, we would not really know that until June of next year.
Madam Chair, Lynn Edkins.
Yes, Lynn.
And I think the thought process of the committee was really twofold. One is that the exchange is going to be bringing a lot of new insurance premium revenue to the state, and also the idea that the state would be saving costs long-term on healthcare insurance because there's going to be more people, or on healthcare coverage because there's more people who are going to be insured. So that's kind of where the entire discussion kind of began. And we kind of stayed away from the politics of it all. We really were trying to say we're bringing a lot more revenue in, maybe a chunk of it could help sustain the exchange, and it just made sense. Again, in light of the recent comments at the hearing, I guess, yesterday, you know, I don't know where we are in that, but that's kind of where that was our thinking.
This is Dr. Ford. Can I ask Ms. Lewis, how did you guys come up with the 25%?
Luan Lewis for the record. Well, in our deliberations, we were trying to look for an amount that was reasonable. And based on the estimates for increased participation and the increased, therefore, premium tax that would accrue to the state, we thought that 25% of that, based on the, the information that I stated earlier, was not unreasonable. So we were looking for a reasonable amount.
Do we have any other questions for Ms. Lewis or Mr. Hager? Okay,
well, Lynette, because I have one question, I guess. So if the board approves asking, I guess, to be included in the budget, this 25%, is there any harm in that? Or, you know, I know it sounds like we shouldn't kind of plan on it. I'm not quite sure. I'm not quite sure kind of the current question pending on the table is, because is it, yes, we are going to consider that 20% and we need that. Do we need Plan B? Do we need, where are we on this?
For the record, John Hager. So I agree that we should not plan on it because well, there's a couple things. So if we provide it in our agency request budget, it will likely be pulled out in the next budgetary process, and then we'll have to explain at the legislative level why there's a difference between the board's request and the governor's request. Additionally, I agree that we should not plan on it, that we should, because if we were to assume that we get it and then we don't get enough fees, then we could end up in the hole, if you will. Right now, we are the 60-day reserve. Let me see if I can find it here. The 60-day reserve, so I'm looking at page 16. It's on attachment A of the Finance and Sustainability Plan, which is attachment B, just to make things a little confusing. So the 60-day reserve exchange budget by state fiscal year, 100% of the federal poverty level. If the exchange does the individual billing, it's about $3.5 million. That's a 60-day reserve. In the documentation, we said that the general fund request would be for that first year. Let me find it. $2.8 million in calendar year 14, so about half of that for calendar year 15, so $1.4 million. So if we requested it, but we didn't change our rates because we were planning on getting it, we would increase our reserve from 60 days to about 90-day reserve. And so then the question is, do we need that much reserve? You know, I mean, I guess that's a question for the board. Do you want to make sure we have that much reserve, or is the reserve that we're charging based on the $4.40 per month or whatever that rate is, it's $4.40 there, is that sufficient to cover our costs? Again, a majority of our funding in fiscal year 14, and that funding is it looks like $20 million for 2014 if our enrollment is down to 100% of the federal poverty level and the exchange does individual billing. So we're getting $20.1 million from the federal government. Do we need an additional $1.4 million from the general fund?
Ron Klein, may I ask a question, please?
Certainly, Dr. Klein.
Mr. Hager, if we don't ask for the 25% of the increased premium credit, how does that change our per member per month price, understanding that it's paid for by the federal government in 2014 and then less so in 2015?
If we don't request the state general fund appropriation, our rate will be $4. And again, this is depending on which one you look at, but
sure.
For now, for argument's sake, about $4.40 per member per month. If we do choose to request a general fund appropriation, that amount decreases. It appears to decrease by $1.62 per member per month. So it goes down from $4.40 down to $2.80-ish per member per month for that first year.
A fairly significant amount. Okay. Thank you very much.
Any other questions?
Madam Chair, this is Leslie Johnstone.
Yes, Ms. Johnstone.
John, what is the timing sensitivity of knowing what that per member per month figure is for the carriers?
The carriers need to start building. The carriers need to start building their plans at the end of this calendar year. They need to basically submit their plans for rate review to the Division of Insurance January, February, March timeframe. The other thing to consider is that if we were to request the general fund appropriation and reduce the rates to $1.62 per member per.
The conference is about to end.
Cool.
Wow. Speed this up. If it reduces to $1.62 per member or by $1.62 per member per month, and we don't get it, then we would, of course, our reserve would be less by that general fund appropriation amount.
Are they taking care of that? The conference is about ready to end, or is it really? Okay, thank you. Give us a high sign if haven't voted yet. All right, what is the pleasure of the board with respect to this general fund request?
I'm sorry, this is Ron Klein. May I ask one more question? I apologize.
Certainly, Dr. Klein.
John, could you tell us again? It's just getting confusing between all the different years we're talking about. The federal government, for subsidized individuals, the federal government takes up the entire per member per month charge in 2014, and then how does that change in 2015?
In 2014, the federal government, through the Affordable Care Act funding, pays for all of the per member per month fees that are charged by the exchange.
Whether you're subsidized or not?
Let me back up. The Affordable Care Act pays for all of the expenses of the exchange. The $4.40 per member per month fee is designed to, number one, pay for the Navigator program, which is not paid for by the Affordable Care Act funding, and number two, to build up the operational reserves so that we can pay our bills in future years. After 2015, all of the expenses of the exchange are built into the per member per month fee, with some adjustments for changes to the reserve. For those that are subsidized, the fee is paid by the advanced premium tax credit. For those that are not, the individual pays for it. The funding from the Affordable Care Act itself goes through calendar year 2014. The request from the Finance and Sustainability Committee for the general fund appropriation goes from January 1st of 2014 through June 30th of 2015.
So what I'm trying to understand is, for those who are subsidized individuals, the per member per month fee is really picked up by the federal government. So by having a higher per member per month fee from 280 to 440 or something like that, that really doesn't change what a subsidized individual sees, because that wasn't part of their premium, that wasn't part of their out-of-pocket expense anyway, because the federal government is picking that up. Is that correct?
That's correct.
Ms. Lynn Atkins, we're confused in Las Vegas, or some of us are. So the $440 a month, how would that show then, based on what you're saying, if somebody signs up for their health care insurance, they're not going to pay the $440 and we're going to get that $440 from the federal government?
So sort of. The $4.40 per month again goes to building the operational reserve for that first year. It would be charged to the carriers. It would be included in the premiums that the carriers charge the consumer. For consumers who are subsidized, that increase in cost would be paid for by the advanced premium tax credit. For those that do not get the advanced premium tax credit above 400% of the federal poverty level, they would have to pay for that themselves. So if you were to...
And that's the same in 2015 as well then in 2016?
Correct, except the rate will go higher at that point because we have to pay for the expenses of the exchange through the rate.
Okay, and one follow-up question. Can you then plug in the number that we were talking about earlier this morning for the premium payment? Is that plus $1, $440 plus $1, $440 plus 60 cents, $440 plus 20? I mean,
so for the, give me just a second. There's a whole bunch of tables at the back of this.
Page 5. Thank you.
So if the exchange does the individual billing and enrollment is at 100% of the federal poverty level, the rate for the first year would be $4.40. Actually, I think I've got a table in there somewhere else that shows it side by side. In 2014, it would be $4.40. In 2015, $6.20. It would end up at $7.74. If the carriers do individual billing at 100% of the federal poverty level, the rate is $4.20 for the first year, $5.52 for 2015, and it builds up to $7.36 per member per month. I hope that answers your question.
Yes, thank you.
Quick question, Dr. Ford. I'm sorry, this might be already said. When would we hear about the general fund money if we didn't request that? What timeline is that?
Well, the legislature ends the first part of June 2013. So we're talking 10 months from now?
Thank you.
So you did request the June?
Right. When would we hear? The governor's budget comes out latter part of January. So the answer is 10 months from now. Oh, latter part of January. Madam Chair, this is Leslie Johnstone.
Yes, Ms. Johnstone.
When you're ready, I might offer a motion.
Yes, please.
I would move that we include the 25% in the agency request, but if the 25% is not included in the governor's budget, that the rate to the carriers be adjusted at that point in the latter part of January, and we go to Plan B at that point and not wait for the entire legislative session to conclude.
Okay, we have a motion on the table. Is there a second? And then I'll ask for discussion.
Second the motion.
Okay.
Yolanda Lewis on the record.
Okay, Ms. Lewis is second, and Ms. Johnstone made the motion. I'm going to open it up for discussion. I guess the proposal that came out of the Finance and Sustainability Committee came to this board prior to us finding out that the feds were going to take care of 2014. I guess my feeling would be this recommendation probably wouldn't be sitting here in this form if that advisory committee had that information when it came forward. Given the budget dilemma here in the state, since we are getting help from the feds, which we had not anticipated, I guess my question would be, is it still reasonable, which was the analysis that the subcommittee worked under, to keep requesting this amount?
And from the carrier's perspective, isn't it going to be extremely difficult to implement as recommended, if not impossible, given the way you have to do your rate setting? I don't know if we can ask for the carriers to let us know, or maybe DOI.
I'm going to open it up for some public comment. I see some people here from a division of insurance as well.
For the record, Adam Plain, Nevada Division of Insurance. The reminder I wanted to make actually hits to that point, and that is the rate setting requirement under the Affordable Care Act requires on-exchange and off-exchange plans to be offered at the same gross premium rate. So when you have your discussion about the PMPM fees charged to carriers and how that's distributed across subsidized and non-subsidized and on-exchange and off-exchange, you have to also remember that a particular plan can only be offered at one rate to everyone. And so that a PMPM fee is blended with a, say, producer's commission rate across all of the policies sold. And so those costs are sort of aggregated together and borne by the entire population and not segmented out towards individual subsections.
Mr. Plain, this is Sean Hager for the record. When do the carriers submit their rates for review by DOI?
Minor change and offer it. It's a different plan.
I am not sure of that answer. Kim Everett, who's here and is an actuary for the division, may be able to better answer that for you.
Ron Klein, may I speak?
Sure, Dr. Klein.
Okay. Well, I agree philosophically with the recommendations of the committee that by having more insured people in Nevada, we're going to increase revenue, and so it's not unreasonable to ask for a portion of that. I agree with that philosophically. I think from a practical standpoint, I would be supportive of not asking for that 25% and just assessing per member per month fee, and I have basically two reasons. First, I think politically it's very, very unlikely that we're going to ask for something. The governor's going to take it out of his budget, and the legislature is going to give it to us. So I think we're going to engender bad will for no positive reason. I think we depend on the governor's goodwill and his administration to move forward. So I don't see any reason to generate those ill feelings for no reason at all. And then I think the second point is that for subsidized individuals, the higher per member per month fee is completely absorbed by the federal government. So by taking 25% from the general fund and lowering the per member per month fee, what we're practically doing is we're taking more money from our general revenue and accepting less money from the federal government. So for both of those reasons, I would be supportive of not asking for general fund revenues and simply asking for a per member per month fee.
Thank you, Dr. Klein. And Ms. Everett, we have you here to answer the question on carriers.
Thank you, Madam Chair. Again, for the record, this is Kim Everett with the Nevada Division of Insurance. I believe the question was, when do carriers file their rates? Are you inquiring as to, with regards to the ACA, the P-pocket changes, the essential health benefits, those rates?
With regard to the plans that will be effective on the exchange on January 1st of 2014.
We're anticipating, thank you for that clarification. We're anticipating that once the essential health benefits have been determined, that the carriers will be able to put their plans together, and once they have the direction from these committees and the board as to what fees need to be built into the rates, then we should be getting those shortly. I anticipate sometime after the first of the year.
Thank you very much. Right, do we have any other discussion? We have a motion and a second on the table to approve the recommendation at 25% from the increase in insurance premium tax from the general fund. Do we have any other?
Madam Chair, this is Leslie. Yes. I just want to clarify the motion that we go to a definitive Plan B if the 25% is not included in the governor's recommended budget.
For the record, John Hager, so right now, if we don't request the general fund appropriation, the rate would be $4.40 per member per month, and if we do, it would be $2.76 or something like that per member per month. So is the recommendation to go forward with it in the budget and to go forward with the $2.76 rate, or to go forward with the $4.40 rate and adjust it in the reserves?
This is Leslie Johnstone. I assume it would be at the lower rate, and then the funding request would articulate the impact on the rate, what that would be.
Ms. Johnstone, I guess my only question on the way that you've posed the motion is that I think we already know, based on the governor's public comments that he made repeatedly earlier this week, that he would not accept a general fund appropriation for the health insurance exchange, that it had to stand on its own merits. I guess then does your motion mean I'm saying that, but we know we're already moving to option B?
Well, I think that from my personal perspective, the request is a fair representation of the options that we have, and he may very well strike it out quickly and not have it included in the recommendation, but I feel some obligation to articulate what the options are.
Thank you.
This is Ron Klein again, but for what reason are we doing that? I mean, it seems like we're going to engender bad will with an administration whose support we depend on for no positive purpose other than to say philosophically we believe this, and I'm not sure I personally don't think that's a good idea, but that's my perspective.
We have a comment from a non-voting member, Ms. Jones.
Thank you, Madam Chair. This is just a technical suggestion for John and his group. Perhaps if there's a desire to go forward with a request for a general fund allocation, put it in the system as an item for special consideration. Therefore, it would not, if it's not being considered, it wouldn't be removed from GovRec removed from agency requests to the governor's approved budget. But if it were being considered, it would be brought back in. Does that make sense, what I'm saying? On the technical issue there?
Yes, and we could certainly do that. My bigger concern is the rates that we provide to the carriers and some understanding of what they expect to be charged in 2014 for their rate review process that's starting this fall and into the winter.
So, Madam Chair, this is Leslie Johnstone. That's why I was trying to get clarification about when we need to tell the carriers the number.
I think the carriers are going to provide their filings to the Division of Insurance probably January, February timeframe. They need to have that information to be able to build it into their rates probably November, December at the latest. Whether I would expect that we wouldn't get an official confirmation one way or another from the governor's office until the governor's requested budget at the end of January is submitted to the legislature. We might get behind-the-scenes confirmations, although I would say that we already have gotten that confirmation.
Madam Chair, this is Leslie Johnstone.
Yes.
If we have to give the number to the carriers before the governor's recommendation comes out, then I would withdraw my motion. I was understanding that we had to give the final number to the carriers January, February, March. So,
my understanding is that we need to help the carriers prior to a final budget being submitted publicly. Is that?
The rate provided to the carrier has to be provided, I would say, no later than November or December. I'm getting some nods from carriers in the audience. It doesn't necessarily have to be done by the time we submit the budget, although it certainly makes it easier to provide a budget that doesn't have to be changed later on.
And my response was more to when do we see the governor's final budget? We're not going to see that in September or October. And so that was my response to Ms. Johnstone. Given that information, then, is the motion still in play, or is the person who gave the first asking to withdraw it? I'm a little confused.
Madam Chair, this
This
is Leslie Johnstone. Based upon that information, I will withdraw the motion.
Okay. Ms. Lewis, you
Under
gave...
parliamentary procedure, I believe once a motion is made and seconded, it cannot be withdrawn. It becomes it belongs to the body.
Okay.
But maybe you need an attorney.
Yeah, I'm turning to our attorney. Thank you for that.
Good.
I'll make it easy. Just vote on the motion as it stands. And then if it fails, then somebody makes a new motion.
Thank you, Mr. Marcher. Based on advice from our Attorney General, he said to vote on the motion. If it dies, if it's not approved, we can come with another motion. So given that advice, I think I'll do a roll call vote on this one. Let me just pull out my... Ms. Lewis?
Yes.
Ms. Ford? Dr. Ford, I'm sorry.
I vote against that motion.
Thank you. Ms. Atkins?
Nay.
Ms. Kerr?
Against.
Ms. Johnstone?
No.
Dr. Klein?
Nay.
And the chairman votes no. So the motion fails.
Good.
All right, if the motion...
Madam Chair, Lynn Atkins, could I make a motion that we take no action on item 2?
Yes, you may.
Second the motion.
All right, so we have a motion from Ms. Atkins, seconded by Ms. Lewis, to take no action on the recommendation. I'll go ahead and I won't do a roll call on that. All those in favor?
Aye.
Aye.
Anyone opposing? The motion carries. Thank you very much. Ms. Lewis, the approval of the Finance and Sustainability Plan in its total.
Yes, there were some other items in the Finance and Sustainability Plan. I hope everyone has reviewed it, including charging user fees for standalone dental projects and charging user fees for standalone vision products, and offering advertising on the web portal. These were 3 other supplemental revenues that we're hoping to generate for the exchange. And with those eliminating, since no action is going to be taken on partially funding the exchange through the general fund, I recommend that we approve the finance and sustainability plan, having removed that particular recommendation.
All right, thank you. Is there any discussion or
And
question?
Mr. Hager, did you have any further comments on the plan?
Just a couple of minor comments. Again, this is an overall plan for finance and sustainability. It includes all the recommendations that have been approved by the board, other than that general fund appropriation, which we can easily take out. It discusses enrollment volatility, expenditures, ACA grant funds, long-term sustainability, short-term viability and operational reserves, carrier fees, supplemental revenues. So all of these things that we've talked about, approved. It's one place to look at it. Additionally, in the attachments, we have 8 tables of budgets. 4 of them are fiscal year, 4 of them are calendar year. And of those 4 options, we basically have budgets that are based on with individual billing, without individual billing, and then with enrollment down to 100% of the federal poverty level, and then one, assuming Medicaid expansion does occur, up to 138%. So the budget that we are going to recommend is with individual premium billing, and if the board decides to not do individual billing, premium billing, we will take that out. We will have that information. We should have that information, as we discussed, in September. But it's always easier to have money in there and take it out than it is to put it back in later. And it's an easy one to reconcile at the legislative level. So we are, and then additionally, we are assuming 100% of the federal poverty level for our lower threshold. We are assuming that Medicaid expansion does not occur. If it does occur, we will have a decision unit, an item for special consideration that will be up to the 138% level that will back us off of that budget. So it gives the policymakers the ability to make that decision later. So you can see, if you start on page 11 of the plan, it has our enrollment numbers, our grant numbers, and that's on a calendar year basis. So the budget that we would submit would actually start on page 14, and it's basically 14 through 16, the fiscal year budget. You can see the enrollment is about half because it's an average for the year, and we're going to start mid-year for FY14. You can see the revenues, and again, the budget we submit is only for fiscal years 14 and 15. So basically, page 14, years 14 and 15 for the fiscal years, and then the expenditures are on page 15. I will note that a couple of those items in contract services, the MIDA assessment and the disaster recovery, are welfare projects that will end up in the transfer to DWSS, the Division of Welfare and Supportive Services. So there's a slight change in that. When we wrote this, we realized, I think yesterday or the day before, that we allocated 100% to the exchange, and we're only supposed to allocate, I think it's 63%. So the cost reduces slightly on the 2014 number. But generally, what you see here is accurate. The rates are what we would include in the budget. So with that, we will include, depending on the decisions that are made, we will take out the tables in here that are not appropriate. Once those decisions are made, we'll leave them in there until that point. With that, I'll be happy to take any questions.
Do we have any questions for Mr. Hager?
Lynn Atkins, for the record, just a comment that Dr. Ford needed to leave. Just wanted to let you know.
All right, thank you. If there aren't any questions on this, first of all, I want to thank Ms. Lewis and Ms. Atkins for all the work that they've done on this committee, and for John and his staff of putting this all together. But then we'll need a motion to approve this plan so that John can submit it to the governor's office for his budget plan for the year, or for the biennium.
Lynn Atkins, I'll make a motion that the Finance and Sustainability Plan be approved, taking into consideration Mr. Hager's comments.
Okay, do we have a second?
Marie, I second the motion.
Thank you, Ms. Lewis. Okay. So motion and second to approve the Finance and Sustainability Plan. All those in favor?
Aye.
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 Anyone opposed? Thank you very much. Yes, we'll have reports from Plan Certification, Consumer Assistance, the SHOP, and Reinsurance and Risk, probably at the September meeting.
Yes.
So then the next item on the agenda is item number 12, which is the request for budget.
Madam Chair, I apologize. I have to leave. I've got a presentation in a few minutes with a few legislators, so
Okay.
thank you very much. And if you have any subsequent questions, feel free to have John contact me.
All right. Thank you for
Thank you.
joining us today.
So this is item number 10, exchange agency request budget. As I discussed in the previous item, the budget that we will be providing will be the ones provided on page 14 through 16 for fiscal years 2014 through 2015 of the Financial Sustainability Plan, with those few minor modifications that I indicated. And with that, our recommendation is to approve the budget as presented and provide staff the authority to make technical adjustments as necessary.
Okay, is there any discussion regarding the agency's request? If not, can we have a motion for approval?
Madam Chair, this is Leslie Johnstone. I'll move approval.
And is there a second?
Marie Kerr, second.
Thank you, Ms. Kerr. We have a motion from Ms. Johnstone, a second from Ms. Kerr. All those in favor of the motion to accept the agency request budget?
Aye.
Aye. Dr. Klein, we still have you there?
Yes, I vote aye. I'm sorry.
Thank you. All right, the motion passes. Next item on the agenda are the staff, or let's see, this is number 11, strategic plan changes.
As indicated in June when we approved the strategic plan, I indicated that we would come back with the updated enrollment figures and dollar amounts. So this item provides those changes based on the budget items. So 1A, previous projections did not include any employees in self-funded plans with 51 to 100 employees in 2016 to 2017. The strategic plan assumes approximately 11% of the self-funded population is from employers with 51 to 100 employees, and approximately 7% of the self-funded 51 to 100 employee population enrolls in exchange coverage. Item 1B, the number of uninsured individuals and the rates of uninsured are based on the Nevada population under age 65. When all Nevada citizens are included, the uninsured rate is expected to be 12% in 2014 and 10% thereafter. Those numbers were created in consultation with the Department of Health and Human Services. Item 2E, 1/3 of the total number of unsubsidized exchange eligible individuals are expected to enroll in the exchange. Item 2G is updated for cost and enrollment, and item 3A, goal 3A, is updated for enrollment. These figures assume no Medicaid enrollment expansion or Medicaid enrollment expansion up to 100% of the federal poverty level. Should the state determine that Medicaid enrollment will be expanded to 138%, enrollment will decrease and costs will decrease, and the per member per month costs will increase. So the recommendations are to approve the strategic plan and provide staff the authority to update the strategic plan for the following reasons. If the state of Nevada determines it will expand Medicaid enrollment to 138% of the federal poverty level. If the Department of Health and Human Services updates population figures, as is typically done in late fall before a legislative session, and minor administrative changes are required for the agency request budget or governor's recommended budget. So basically, we request that you approve this recommendation for the plan and adjust it, and allow us to adjust it for these three reasons.
Do we have a motion to accept staff's recommendation on the strategic plan?
Lynn Atkins, so moved.
Do we have a second?
It's Leslie Johnstone. I'll second.
Thank you, Ms. Johnstone. All those in favor of the motion?
Aye.
All right. I think that's all ayes. Any objections? Motion carries. Item number 12 are staff quarterly reports.
For these items, we were just notified that we're going to be disconnected at 12:15, so we've got 20 minutes left. We can go through these if you'd like, or just have them available for the board's review. It's up to you.
Do you need a motion on any of this for approval from the board, or can we take it for information only?
We could take it for information only.
I mean, there isn't anything administratively that you need to have board approval on this?
I don't think so, no.
Okay. Are there any members that have any questions about the financial report and the consumer outreach report? There being none, let's just accept.
Excuse me?
Are there any questions on the quarterly reports from staff on the financial report or the consumer outreach report? If there are none, we're going to take this as information to be given to the board for our review, but we don't need to approve it. Okay, hearing none. Item 13, discussion and action for possible items to appear on the next board meeting agenda.
So items that will likely appear in the September board meeting agenda are those committee recommendations that have not yet been reviewed, as well as any other item that's on the board calendar. I believe the MOU is one of those items. If there's, we'll take any requests for added items if there are any out there.
Madam Chair, I have a question. It's Lynn Edkins. It seems to me this meeting, obviously, there was a couple of issues that required a lot of discussion amongst the group. I anticipate at the next meeting there's going to be a lot of questions about the consumer assistance recommendations, just because it was a very heavily discussed item at our subcommittee meeting. So I'm just wondering about timing. I mean, I'd rather know if we think we're going to need more time at the meeting so I can, clear my calendar. So I just ask for calendaring purposes. The meetings, I think, are going to start getting more longer.
I appreciate that, Ms. Atkins, because I know that we've typically scheduled 3 to 3.5 hours, and we're bumping over 4 hours every time. So I appreciate your telling us that you think that those discussion items will take longer. Oh, yeah. Well, I'm just saying past ones. Today's been a long 4. But when do you want to?
So if we started this at noon on September 13th, that would give us 5 hours, 12 to 5. There may be some committee recommendations that we could, if we go longer than that, there may be some recommendations that we can postpone till October if we have to.
Ms. Atkins, are you suggesting maybe a full day? Are you thinking that it's going to take that long?
No.
Okay.
No.
Thank you. Thank you.
I had in my my calendar shows 1:30 to 4:30 though for the next meeting in September, and I thought all of them were scheduled at 3 hours, and so, we're at 4 hours. We're at 4 hours today, aren't we? Mm-hmm. Yes. So
I don't think we've had a meeting that they haven't threatened to cut us off. So I know that we utilize every minute that we've got. So do you want to schedule 5 hours then?
Yeah, I can schedule from noon to 5 next time, and then if we go over 5 hours, we can prioritize some of the recommendations and postpone them to the next meeting if we have to.
I'm the most hated person in Las Vegas at the moment, and I don't even know that I thought we need 5 hours. I just don't think 3 hours is sufficient. I think we're going to have the discussion again from this morning, so maybe in the middle of 4 hours or something. I don't know. I'm just, Dr. Ford had to leave. I don't know about Dr. Klein's schedule. Everyone's got scheduled things.
Okay, we'll schedule it for 1 to 5 on September 13th. It's a half hour earlier, half hour later. We will make sure that we prioritize the agenda so that if there are items that are going to run over, we can push them to the next meeting if necessary.
Good. All right, thank you. Those were great comments. All right, if that takes care of the next board meeting agenda, then now we're to public comment. Do we have any public comment here in Carson City? And we are going to limit it to no more than 3 minutes, or else we won't hear it anyway.
Madam Chair, thank you very much. Members of the board, Jim Mullen with Delta Dental Insurance Company. I spoke previously. I just wanted to make brief mention of the presentation by Xerox this morning, which obviously did not go into any great depth. I will note, however, that standalone dental plans were not mentioned in the RFP that was issued by the state exchange board. And so I don't think that's anything of great concern. I spoke with them during the break about the placement of standalone dental. Enroll UX 2014 that Mr. Hager mentioned, the project that was funded by various states and HHS, does place some emphasis on dental, but we don't think it's prevalent enough. So they understood our point. I just wanted to raise for the board that there are some policy issues around the placement of standalone dental carriers. They are considered an accepted benefit, so not all of the certification requirements, for instance, things like accreditation, rate review, apply to dental plans. Also, the placement of standalone dental within the web portal that Xerox will be building may need some policy direction from the board. And so I just wanted to raise that as an issue, that we're here happy to help and assist in that. I think we've submitted some information to Mr. Hager on our position on what certification requirements could apply and should apply and how. Things like network, for instance, we would fully agree to, but it just needs to be dental specific and not just one size fits all. So we are happy to help, and we'll reach out to through Mr. Hager to see when that might be best positioned to happen. Thank you.
Thank you for your comments. Any other comments here in Carson? How about in Las Vegas? Any on the telephone? Well, given that, I think we wound it up by 12:15. Thank you, everyone, for all of your time and consideration and hard work on this. All of us appreciate it. So with that, I'm going to adjourn the meeting, and we'll see you at the subcommittee meetings. Thank you.